and hand over to Dr. Chaudhary.
Going live.
Chaudhary.
Yeah. So he'll introduce, yeah? And then
then he'll send it to me, then I'll hand over to you, sir.
Sure.
Yeah.
So my introduction is just a very brief thing about...
we are live now, sir. A very good afternoon from Ortho TV side. Today we have a webinar of Bihar Orthopedics Proximal Shoulder. I'm now handing over to our Secretary, Dr. Rajiv Anand, sir.
President. So I think good afternoon, everyone. And it's a matter of great privilege that this is our fourth webinar which we are conducting today is on fracture proximal humerus, and eminent faculty from India and as well as abroad are with us. I'll just name them: Dr. John Mukhopadhyay from Patna, India; Dr. Vikas Agashe, Mumbai; Dr. Radhakant Pandey from Leicester, UK; and Dr. Thira Chai Apivatakakul from Thailand.
Mr. Ashish Babulkar.
Dr. Ashish Babulkar from Pune. So on behalf of Bihar Orthopedic Association, I welcome all the faculties and all the viewers for this fourth webinar on proximal fracture humerus. So I'll hand over to my president, POA president, Dr. Manoj Chaudhary, to say a few words.
Dear audience.
Is he here?
Yeah, he's there. Yeah, you need to be a bit louder, Manoj.
Oh, dear audience.
It's better.
Am I audible?
Yeah.
Dear audience, delegates and faculties, I, President Bihar Orthopedic Association, welcome you at the fourth webinar of POA, and the topic of discussion is proximal humerus fractures. Esteemed national and international faculties and panelists are taking part. I am happy to find the name of Dr. John Mukhopadhyay. Whenever I see his name, I become nostalgic. Well back in our early days, we were working together in Patna Medical College Hospital. This webinar is important as we have included non-operative treatment part also. The recent trend is we try to operate in most of the cases. This is drift towards right. We are forgetting the art of non-operative management. I am sure this webinar will create some interest in non-operative treatment also. It is an interactive session. I request you to kindly take an active part by asking questions. For this, contact numbers have been given. Please do not forget to mention your name. I repeat, please do not forget to mention your name while asking questions. Dr. Rajiv Anand, Secretary and Chairman of IOA CME Committee, will be moderating the session, and I am now giving it to Dr. Rajiv Anand.
Yes,
thank
sir.
you.
Well, thank you, sir. Thank you very much. Now, without wasting much of your time, I'll just hand over the baton to Dr. John Mukhopadhyay, who will introduce the course. Dr. John Mukhopadhyay, please.
Yeah, so thank you very much and welcome everybody to this webinar. I think in these days of the COVID pandemic, we're also having an epidemic of webinars. So when Rajiv asked me to organize one on proximal humerus, I was trying to look at what we can do which would be useful for people who are attending the webinar in terms of their daily work. And I think we've got an excellent faculty together, and I really thank all of them for being here with us today. We've got Mr. Pandey from Leicester, and he's going to talk to about conservative management of these fractures. And this is important because proximal humerus fractures, many can be managed conservatively, and this is even of more importance today in the COVID era where you want to avoid any surgery that is not absolutely necessary. Okay, we have Thira Chai from Chiang Mai in Thailand, and he's the leading person in the world on minimally invasive techniques of various fractures. And also the editor of the AO book on minimally invasive plate osteosynthesis. And it's great to have Tirachai here with us to talk to us about the techniques for minimally invasive fixation of the proximal humerus fractures. Vikas Agashe from Hinduja, Mumbai, who all of you know, and he's going to give us a brief introduction on the surgical anatomy, as well as talk about the conventional methods of open reduction and internal fixation. I'll be talking on salvage and neglected fractures and failed fixations, while Ashish, again, worldwide expert on shoulder, both on arthroscopic, arthroplasty, as well as trauma. And it's great to have him here today to talk to us about the indications for arthroplasty in proximal humerus fractures, where fixation is likely to not succeed, and the techniques and the options that we have in the reconstructive ladder in treating these fractures. So it's great to have all of you here. And I think without further ado, I'll hand over to Vikas, who's going to first go through a brief talk on the relevant surgical anatomy for proximal humerus fracture. Vikas.
Yeah. Good afternoon, friends. It's a great honor to be here taking part in a webinar on proximal humerus fractures. I'm sure most of you would say, oh my God, you are talking of anatomy. So the idea today is not to have a formal talk on anatomy, but I just briefly touch a few points which we very often overlook as regards surgical anatomy is concerned. We all know that the shoulder has four articulations, and the main joint, or the glenohumeral joint, is a ball and socket joint. The socket size is increased by the labrum. Now, something which we often overlook. Shoulder is a class 3 lever. That means the fulcrum is here, the load is far away, and the effort is in between. Same thing shown here. That's the shoulder. That's the deltoid muscle, which is the force, and the weight is well away. Now, essentially, class 3 levers are not very efficient, but they help you in fast movements like this. The class 1 lever is very, very efficient. Class 3 is not. And therefore, the shoulders for such rapid movements need to have very large muscles. And that is why we have large muscles like deltoid, the serratus, the pectoralis, the latissimus dorsi, and so on and so forth. Now then, there is a downside. When the large muscles are in the direction of the humerus, you know what would happen? The humerus would be just shifted proximally. And to prevent that shift, the head of the humerus is held very, very well or stabilized by the rotator cuff. As you can see here, the rotator cuff just holds the head of the humerus against glenoid. A common simile: when you try to lift the ladder by a force here, unless this man stabilizes the ladder by holding his leg here or foot here, the ladder will just keep shifting. And that is why, as you can see here, the rotators hold the upper end humerus well. That's the articulation, and the deltoid is working far away. So the class 3 lever helps us in having fast movements. The efficiency, it is made strong by very strong muscles, but the upper end humerus is held very well by the rotators. And therefore, the tuberosities in proximal humerus, which give attachment to these humerus, are very, very, very important in fractures of upper end humerus. Because of the proximity to major vessels, the vascular injuries are rare but must be identified. For example, here this man came in with absent pulse, cold limb, and if you can see here, the large ecchymotic patch in the axilla is a giveaway. Most of the times when the patients come in on second or third or fourth day, there's a significant ecchymosis distally, distal part of the arm. But this ecchymosis in the axilla was a giveaway. So here you can see there's a complete block at subclavian and axillary vessels, which had to be repaired by using a Dacron graft. Of course, we did a fasciotomy and stabilized the humerus. Once in a while, the screw cutout also can lead to injury to the vessels. That's something like an iatrogenic injury, as you can see here. On 12th day, the humerus fixation gave way and patient bled a lot. Axillary artery needed to be repaired and had to be re-explored twice. This is what was published in JBJS 2007. The axillary, the brachial plexus is also very near the humerus, and very commonly, especially while doing a coracoid osteotomy, the brachial plexus is likely to get injured. Remember, when you abduct the shoulder, the brachial plexus comes very, very near the coracoid, and therefore the arm needs to be adducted while doing a coracoid osteotomy. The importance of axillary nerve in MIPO, I'm sure Dr. Tiruchai will discuss at length. Talking about the blood supply of proximal humerus, it is the anastomosis between anterior and posterior circumflex humeral arteries that supplies the upper end humerus. Now, what is important is, as you can see here, the ascending branch of posterior humeral artery perforates the bone here, and the ascending branch of anterior circumflex humeral artery perforates here. What is important, as you can see here, it is closely related to the bicipital groove and long head of biceps tendon, and it perforates just medial to the or at the bicipital groove. So any gross dissection here, putting implants here is very likely to injure the anterior, the ascending branch of anterior circumflex humeral artery. Now, there are people who say that the long head of biceps just works as a stabilizer, but as far as the real action is concerned, it's just vestigial. And therefore, many surgeons do tenodesis of long head of biceps while fixing the proximal humerus, and they feel that the results or function-wise results are much better. Lastly, as you can see here, the trabecular pattern significantly deteriorates with osteoporosis. That's the upper end humerus at 30, that's the upper end humerus at 70. Though we hardly ever do DEXA, rather the real indicator of osteoporosis is hip, but we should remember that because of osteoporosis, a significant comminuted fracture can occur, and the implant holding or anchorage of implants is very, very poor. Lastly, there is a concept called metaphyseal torus concept that is being introduced in the upper end humerus, and you can see that it is in three columns that support the head of humerus. The anterior-lateral and posterior-lateral column, also called distraction zone, it generally is paucifragmentary, but rotator cuff function problems are common. The second zone is, or the column, is the anterior-medial column. This is a tilting zone, and that actually reconstitution of this will prevent tilting of the head of the humerus. It is generally quasi-fragmentary, and because of the importance of blood supply, this can lead to perfusion problems. And the posterior medial column, as you can see here, and that's a crumple zone. The generally it is the region gets crumpled, and unless reconstituted well, the head of the humerus is very likely to fall down. And again, this will have a multi-fragmentary fracture, and there would be a perfusion problem because of posterior circumflex humeral artery. So this, friends, in short, are a few important points you need to remember about surgical anatomy in dealing with proximal humeral fractures. Thank you very much, friends.
Great. Okay, thanks very much, Vikas. That was great. What I forgot to mention in the initial part is that after the fourth talk, that is Tirachai's talk, we'll have one round of case discussions, and then we'll have the last two talks and the final round of case discussions. Okay, so Rajiv, if there are any questions, you can.
Till now there is no question as such, but soon after the second talk, if the question comes, I'll go back to Dr. Vikas.
Meanwhile, if Pandey, you can share your screen, and then we can get started while the.
So I invite Dr. Radhakant Pandey from Leicester, UK, and he'll be talking on conservative management of fractured proximal humerus.
Great,
Can you see my screen?
Yeah, we can see very clearly. Good.
Okay. Good morning from my side. I think you have good afternoon there. So let me talk about non-operative management of proximal humerus fractures. Only a few years ago, most of these fractures were treated non-operatively. We were told only about 10 to 15% of proximal humeral fractures need surgery. But unfortunately, that is not the trend these days. There is an increasing trend to fix more and more these fractures. So hopefully with this coronavirus, the pendulum will swing back a little, because we probably need to operate less. So that, as I said, the trend is increasing, both with surgical fixation and replacements for these fractures. Now I will show you this X-ray, which is being fixed with locking plates. Now, all of you will agree that it's a reasonably well fixed proximal humeral fracture. The fracture has healed and it's in a reasonably good position. So patients should obviously get fantastic results. But that is the clinical picture of this patient. As you can see, the normal arm has got about 170 degrees movement, and the operated arm has got only 90 degrees of movement, almost 9 months after surgery. So what I'm trying to tell you is, just because you get a good X-ray and the fracture heals doesn't necessarily mean that you will get a good outcome. Now, this is another X-ray of somebody with a 3-part fracture. The tuberosity is quite displaced, and this patient was sent for surgery. So I talked to him, gave him various options, including non-operative management, and he was a bit scared to have surgery. So he said, "Can I choose non-operative management?" I said, "Fine." So he started to heal in few months' time. And this is the movement he had as 7 months. He is delighted. And you can see, yes, there is a slight restriction of movement, but I don't think you could have guaranteed him full range of movement with even putting the best plates or nails inside. So for all practical purposes, this guy is doing very, very well. I will show you some more difficult cases. This was you can see the tuberosity is almost flipped. And you would think, why would you even think of treating this non-operatively? But this patient had a stroke only a month ago and has got certain other problems with his heart. So we talked to him at length, and we were wanting to do a reverse shoulder or a hemi-arthroplasty. He was not keen on surgery. So we said, okay, you take your chances. So, sorry. So he came back, we followed him up, And this is what he is at a year. Now you would think, that doesn't look quite good. But if you see the corner, this is the lady who can, an English lady who can drink her tea, eat her food, and do most of her daily activities. And she's got no pain. So if you look at the initial X-ray, you are probably looking at replacing this joint. If you were doing a hemiarthroplasty, I don't think you'll get better result than what you had non-operatively. And if you're going to fix this fracture, there is a reasonable chance of it failing. So non-operative management, I'm not suggesting that you do it for everybody, but if you choose your patient properly, you are likely to get fairly good results. Now, this is again somebody who was sent for surgery, we discussed, and this patient went on to heal. And this is the patient who's one of my happiest patients. He even brought me a bottle of single malt whiskey, which is the best outcome measure I have known. So beware, I would say. Surgical treatment is increasingly being used, increasing the treatment cost of shoulder fracture. And I think in these days, with the coronavirus, we need to think about patient safety, staff safety, and the surgeon safety. So maybe we may want to start reading the Charnley's textbook of non-operative fracture management again. And there is a very nice Cochrane review done. Surgery for displaced fracture of the proximal humerus may not result in better outcomes than non-surgical management. So yes, we are operating a lot more, but we haven't actually shown that that has generally improved the outcomes for as a whole. I mean, for individual patients, you may definitely increase outcomes with surgery. Now, all of us have got a collection of these kind of X-rays, and John has probably got the highest number of collection of these kind of X-rays. And you may get one patient who you made significantly better, but most of us have amnesia when they come to say, oh, for every one patient they have made better, they've also made one patient worse. So remember these kind of X-rays. Now, I am not saying you don't operate on proximal humeral fractures at all. Now, if you have a greater tuberosity fracture, which is off, you fix it. Fracture dislocation, you fix it or replace it. Lock posterior fracture dislocation, you fix it or replace it. The very displaced fractures, you have to do something. Completely displaced fracture, you may have to put a plate or nail. So there is plenty of fractures in the proximal humerus which can be treated surgically. However, I'm talking about these kind of fractures. Now, if you look at these kind of fractures, you think, yeah, they are broken, they look displaced, but you'll be surprised how well the shoulder does with a bit of non-union. It is very, very forgiving, and the risks are very, very small. And just because you're treating something non-operatively doesn't mean you miss the boat. You follow them up, you see whether the fracture is healing or not, whether they are progressing or not. You can change your management plan 3-4 weeks down the line, if need be. But all these patients I'm showing you in front of your screen here, they were all listed or sent to us for surgery, and we all treated them non-operatively with reasonably good results. So this is another of my patient, which was, I mean, this could have, everybody knows that this can be treated non-operative. This is not very, very displaced. The tuberosity is in reasonable place. The shaft and the head are reasonably well aligned. Why would you operate on this? This will give as good, if not better results with non-operative management than with surgery. Remember, proximal humeral fractures are almost, I mean, I would say 80% soft tissue surgery and only 20% bony surgery. And if you don't respect the soft tissues, which can be difficult with surgery, you are not likely to get very good results. But this is, again, this is the same guy. He's got full range of movement post non-operative management. This is a lady who's got a malunited. So we call it, or Maheshwari in Delhi calls it, the acceptable malunion. She's driving a car and pleased with whatever she has achieved. So I'm sort of touting non-operative management. Is there any evidence? Now, this is a huge trial, and I'm sure most people would have heard of PROFA trial, but there are some misconceptions with PROFA trial. They seem to think PROFA trial tells you that you should not operate on proximal humeral fractures. That's wrong. PROFA trial is a pragmatic trial. It's a randomized control trial. The people who were included in this trial were people who the surgeon saw the X-ray and he was not sure whether to operate or not to operate. So the ones which needed operation, surgeon went ahead and did the operation. The one they thought, oh, this can be treated non-operatively, they were treated non-operatively. But only those X-rays, and I'm sure all of you face this dilemma every day. You look at an X-ray of the proximal humerus and you're thinking, oh, whether I should leave it or operate. Those cases, if you leave them, treat them non-operatively, they will do as well as operation. I hope you get the message. It is not operate or only non-operative. It is for those cases which you felt in equipoise. That means you were not sure whether to operate or not to operate. And those are the ones, if you treat them non-operatively, you will do as well. So the trial results do not support the trend of increased surgery for patients with displaced proximal humeral fractures. All displaced proximal humeral fractures need not be operated on. So how are we going to do the non-operative management? And I think the most important thing is you have to actually give that option to the patient. You have to say there is another option of non-operative management. In young patients, 30, 40, obviously you have to individualize. Those ones you are more likely to sort of operate because you don't want too much malunion. But whether to operate or not to operate, the most important thing, as has been said earlier, is the displacement and the stability of tuberosities. Tuberosities will decide how well your shoulder is going to do. So if you have decided to treat something non-operatively, this is what we do here in Leicester. We put them into a sling. We take check X-rays every week if required. And at 2 weeks, we start pendular exercises with an X-ray, and we start passive and assisted exercise at 3 weeks, active exercise between 4 to 6 weeks, strengthening at 3 months. Obviously, this is not what you need to do, but this is a rough guidelines, and it all depends on your tuberosity. Your check X-rays, which you take serially, is to look at the tuberosities. If the tuberosities start to move away, then you need to do something. And as I said, young patients, you may have to treat them slightly differently. So this, let's have an example. So this is a fracture, and I may ask you, and I'm sure that a lot of people will say, that can be, it should be operated on, and I would beg to differ. So you look at the humeral head here, it's facing in the right direction. This is the tuberosity. Yes, it's comminuted, but it's under the head and it's in the right position. If you look at the lateral, most things look roughly in this place where they should be. So although the X-ray looks, wow, that's comminuted and let me do something about it. But if you look at it very, very critically, you can get a CT scan, make sure there is no head split. But if the capital fragment and the tuberosities are in roughly the place, if they're, so the Neer said it should be, if it's displaced more than one, it's fragment. I don't worry too much about 1 centimeter. If it's roughly in the same place, I would treat this non-operatively. And this is at about 3-4 months. This is at about a year. And you can see the patient's got very good range of movement, and he was very, very happy with what he had. So even if you'd done an operation, I doubt if you had guaranteed him that kind of movement and you would have put him through some risks. Thank you very much.
Thank you, sir, for
so while we get some questions in, so can I ask one question to Dr. Pandey?
Yeah.
So what is your decision on treating non-operative? What are the things that you look at the X-ray to make you think that this patient definitely needs surgery or it may be suitable for conservative management?
So if we go back to this X-ray, As I said, the most important thing is where your head and tuberosity is lying. So even if the tuberosity is gone about a centimeter at the top, if the majority of the tuberosity is in the reasonable, it's not sort of pulled out and gone posteriorly significantly, 1 centimeter I don't think makes a difference. If it's completely off with no contact between the shaft and humerus and the tuberosity is completely off, those ones you may want to make sure the tuberosity is brought back into place. The humeral head, again, you can take about 15 to 20 degrees or even 30 degrees of tilt in either way, because humerus has got very good range of movement and it can compensate. So it looks at the capital fragment, how angulated that is, how displaced this tuberosity is, and if there is no connection between the humeral shaft and these two fragments, then you may think of surgery. But if there is even 25, 30% contact between the shaft and the rest of the fragment, and most other fragments, the tuberosity and the head, are in a reasonable position, I would go for non-operative management.
Yeah, that's interesting because,
Yeah.
and is your conservatives, the sling just a regular sling, or you have a shoulder immobilizer kind of thing?
Yeah, but no, it's a poly sling, so it supports the elbow also.
Okay.
So sometimes, or if you want to use a normal sling, then it has to be a double sling so that the elbow doesn't drag down and gravity doesn't pull everything down. So
Okay.
we support the elbow also. But
Okay.
many times we have to ask the patient, try and sleep slightly propped up position, don't lie flat. And if you
Okay.
sit in a slightly propped up position, they are more comfortable.
Yeah. So Rajiv, any question?
Yeah, it's an extension to your question itself, that the same question being asked, like whether the sling or immobilizer, and how many weeks? Is it 2 weeks or 3 weeks? Because the standard teaching is for us is that it glues in 3 weeks.
No.
Any comment?
There is no teaching like that anywhere. I have read extensively about these things. Everybody has got opinions about these things. Sometimes if you see like I'll show you an X-ray, I'll just show you. This one, we mobilized immediately. We did not put them, we put them in a sling, but I had advised him to take the sling out every day and start gentle mobilization as he could. Whereas if you get somebody like this, maybe you want to keep them in a sling for a week or two. But what you don't want to do is to put them in a sling for long periods of time. Remember, there's a lot of soft tissue there. 2 weeks maximum. After that, they must start moving to a certain degree. How much they move, it'll all depend on how bad the fractures are.
Yeah, and the other thing that you do notice is just putting them in a sling sometimes over a period of time actually does reduce the fracture to some extent.
Absolutely.
Yeah.
That's very important point I should have said. If you look at the first X-ray after the injury, immediate trauma X-ray, that always looks bad. If you do the same shoulder a week later, in which the patient can bring the arm in neutral position, not internal rotated or external rotated, the X-ray always looks a lot better. And if you do a CT scan, don't willy-nilly do CT scans for everybody. You need to know why you're doing the CT scan, because CT scan always looks worse than the X-ray.
Yeah.
So you just be careful when you do CT scan. You need to know why you want to do the CT scan. And I would do CT scan if you want to see a head split, if you are seeing the greater tuberosity is split or comminuted. Those are the two main reasons. And sometimes you want to see if there is significant displacement of the fragments or not, which you can do most of the time with 2 views. Always do 2 views for a shoulder injury.
Right.
Yeah, one more question from Indore. Dr. Saket has asked, like, is there be any role in geriatric patient of denosumab or teriparatide along with the conservative management? Do you prescribe denosumab or teriparatide?
I'm really sorry, I don't know what those two are.
Teriparatide is parathyroid hormone for osteoporosis, basically.
For the osteoporotic fractures in the geriatric patient, he has asked whether we should give teriparatide or denosumab which is a parathyroid hormone.
I think we are slightly different here in NHS. If we think patient has got an osteoporotic fracture, we send them to the metabolic bone disease people, and they do everything and they treat them properly. I think this small treatment for osteoporosis can be a bit dangerous because you need to know what osteoporosis is, and it has to be a prolonged treatment. If you give patients for 2-3 weeks, whatever you want to, I don't think it makes a huge difference. If the patient has got osteoporosis, that has to be treated properly. They may need a DEXA scan and then go for treatment. So we don't generally give the parathormone or this thing, but if we feel that there is osteoporosis involved, yes, it is treated properly.
Yeah, I think so. The parathyroid hormone, especially teriparatide, is being misused a lot as something that helps fractures heal. It's a treatment for osteoporosis, yes, but I don't think it should be assumed that it helps the fracture to heal.
Yes. So I think, thank you very much.
Dr. Pandey, yeah. Actually, this is not a question. I will support you and your views. There are many articles and there are many literature in the literature, and they support your views. And sometimes they mention this CM score as high as 72. So I think this has to be considered as a modality of treatment.
Okay, so I think Vikas, you can start sharing your screen.
Yeah, sure.
Yeah.
Yeah.
So once you have decided that you're going to do open reduction and internal fixation.
Put it on full screen, Vikas. Yeah, great.
How do we proceed? Whether to operate or not, whether to do open reduction or not is not what I am going to discuss. It's only after you have decided that you're going to do open reduction. Finally, what are the aims of any shoulder surgery? Activities of daily living. Most important is activities of daily living. You need good range of movement, good abduction, adduction, good rotations, especially for eating, combing your hair, and toilet activities. And of course, in some cases, you need some extraordinary actions. We keep talking of various implants. You attend any workshop or symposium, the first thing that comes to your mind or the first thing that is taught is whether you would do a plating or a nailing, which company, what length, which screws where, or which nail, which generation, so on and so forth. How to expose the fracture, how to expose for implant insertion, and of course, avoid implant related complications. And we come back with a lot of material as related to this. And the first thing we do is, yes, I mean, when you have a fracture dislocation like this, anterior fracture dislocation, you can see you are able to do appropriate open reduction and internal fixation. As you can see here, the plate applied properly. The position of the plate is fantastic. The angulation, the normal humerus is almost reconstituted. And the fracture is healed well, and the patient has got excellent result. The one fantastic paper by Ashok Gavaskar outlines this commonly used implant, that second generation lock plating for complex proximal humerus. And the authors describe that you should have 7 locking head screws, including 2 calcar screws, augmented with traction cuff sutures. The comminuted, in case the medial calcar is comminuted, you need to have an industrial fibular strut. And for a subchondral metaphyseal bone defect, it has to be filled with injectable calcium phosphate cement. And this is how they have described this, and the results have been very, very good functionally also. Now, when we talk of principles of open reduction and internal fixation, yes, these are extremely important, but what is not often discussed is the software, and that is getting reduction, how to get reduction, how to get stable reduction in severe osteoporosis, how to improve the stability of reduction and purchase of reduction, and most important, how to prevent tuberosities flying off. So as I discussed in anatomy, this is a torus concept now, and you can consider the head of the humerus is supported by a three-legged stool. You can see the head of humerus is already slanting. So this three-legged stool plays an extremely important role in supporting the head of the humerus. So the aim is to reconstitute this three-legged stool. And fracture reduction, we can use spikes, K-wires, joysticks, so on and so forth. The first step, of course, is doing a CT. I would like to know whether the head is split. I would like to know whether there is a comminution. I would like to know where are the tuberosities and whether they are comminuted also. So that's a glenoid. I would like to know whether there is a head split, and I would like to know what are the different ways of or different types of head split. You could have a main posterior fracture line. You could have an anterior fracture line. You can find out with the CT whether there is a central area which is articulating with the glenoid, but there is an anterior fracture line and there is a posterior fracture line, or whether there is a head which is just burst into several pieces. So if there is a head split, you need to plan how you are going to reduce the head split, and then how you are going to reconstitute this three-legged stool. So in a 3 or 4 part fracture, putting back the head can be done, or addressing the head can be done through the rotator interval. As you can see here, the rotators are already split or they are separated, and then you can address the head of the humerus through this rotator interval and reconstitute the medial hinge, reconstitute the head on the medial hinge. A temporary K-wire can be inserted. Then the lateral cortex can be reconstituted. Here you can see the lateral cortex is restored, or the greater tuberosity is restored. You still have the anterior or the lesser tuberosity away, through which you can keep seeing the reduction, and then at the end the lesser tuberosity is reconstituted or put back into position. As I said, K-wires, joysticks can be used, or spikes can be used to lift the head. The most important thing is see to it that tuberosities don't fly off, because the rotator and they remain stable. The head has to be stabilized by the rotators. So here you can see the 3 rotators attached to the greater tuberosity. That's the rotator attached to the lesser tuberosity, that's the subscapularis. So once the medial hinge is reconstituted, or even before that, one can take sutures through the rotators. You could use 5-number ethibond for taking sutures or pull out sutures through the tuberosities and pull them down. Once tuberosities are pulled down, the sutures can be passed through the head as well as the shaft to get a semblance of anatomical reduction of the head. Then this can be maintained by 1 or 2 K-wires, and the most important, the sutures can be passed through the plate or holes of the plate, they are passed before the plate is seated and fixed, but they are tied only after the plate is fixed to the shaft. And of course, we know most of us operate in beach chair position, use a deltopectoral incision. The incision is an internervous plane. Now, there are some drawbacks of deltopectoral incision. The deltoid is a large muscle. Getting the posteriorly displaced greater tuberosity, most often the greater tuberosity is shifted posteriorly. Getting posteriorly displaced greater tuberosity becomes little difficult. You need to abduct, externally rotate, and hook the greater tuberosity under the deltoid and stabilize it. Also, application of plate also needs decent retraction of deltoid so that this plate is seated appropriately. But of course, it is a major workhorse. Most often used incision is the deltopectoral incision. One thing I forgot to mention, the long head of biceps works as a lighthouse. Long head of biceps works as a lighthouse, and it takes you between the lesser tuberosity and the greater tuberosity, and they can be brought together. The most commonly used implant is the lock plate, which offers angular stability. And as you can see, the screws are divergent and convergent. It's a combination of screws in various directions so as to give maximum purchase in osteoporotic bone. Now, as regards plate is concerned, you need to consider the plate positioning so that there is no restriction on movements. The plate should be optimally placed so as to have optimal direction of the screws, and the calcar screws are also appropriately placed. So generally, the plate position needs to be about 8 millimeters below the greater tuberosity. One could use the block and a small K wire of 1.2 millimeters is passed like this and confirm that it is just touching the upper part of the head of the humerus. This gives you a proper position for the locked posterior plate, locked proximal humerus plate. From the bicipital tuberosity, it should be about 8 to 10 millimeters away so that it is placed right in the center of the greater tuberosity. It should be about 8 millimeters caudal to the greater tuberosity so that there is no impingement during abduction. Now, as regards screws are concerned, proximally, we need to have maximum number of screws. The length of the screw should be such that they are about 8 to 10 millimeters away from the subchondral bone. One should see to it that there is no penetration of the screws, and for optimizing purchase, one could use calcium phosphate cement. Distally, using the screws, one should be careful that you don't use a cortical or a non-locking screw here, because otherwise there would be a secondary displacement after you have already achieved the reduction. Distally, avoid putting a lock screw because otherwise chances of stress risers are very high. Now, placing the calcar screws. This paper suggests this experimental study, but it is best what they say is avoid missing high. Don't miss high, in the sense the plate can be little distal. Plate should not be too proximal to have an appropriate purchase. So just to run through some cases, here you can see this is a young patient who has a valgus impacted fracture. You can see the tuberosities are markedly displaced. That's a neck which is into valgus stable, but the tuberosities are markedly displaced, and this would definitely lead to impingement. So one has to really plan this well. Here you can see there's a valgus impacted fracture. Tuberosities are riding high. So the aim is to lift the head between the tuberosities, support the head like eggshell, realign the tuberosities, and fix. So go between the tuberosities, lift the head, support the head, create the medial buttress well, close the tuberosities, take sutures, fix the lesser tuberosity to the head so that close this container. As you can see, the container was split. The head was in valgus. So the head position, the egg position is maintained. The container is appropriately reduced and stabilized. And this is immediate post-op. Here you can see the tuberosities, and that's range of movement, extremely happy patient. Sometimes you have a very challenging situation, markedly displaced head of humerus in a patient who has multiple other problems, markedly restricted shoulder movement. And here you can see the patient also has significant osteoporosis. So here the aim is stabilize, but achieve a stable reduction. That means shove the distal fragment into proximal fragment so that you have a good stable reduction, and then go back. Patient has got back whatever range of movement she already had pre-treatment. Also she had markedly restricted movement. We have gone back to that with a very good stable reduction. So in an osteoporotic patient, aim for a collapse, aim for docking distal fragment into proximal fragment, and then getting a stable reduction. Sometimes the osteoporosis can be very, very significant. As you can see here, this is, you can see very severe osteoporosis. So you need to have a good reconstitution of the proximal as well as distal fragment. And here a femoral head allograft is used. As you can see, femoral head allograft is used, that is put inside. So that's the patient's head, that's the femoral allograft, which is temporarily stabilized, and that gave a very good stable reduction, and which is now supported by proximal humerus locking plate, and that's intraoperative, and that's postoperative. Now, what is important is addressing varus. Avoid varus, one can have a very good result. The screw penetration needs to be avoided. If varus is avoided, screw penetration is avoided. The screw penetration can be early, that is during surgery, or screw penetration can be late, that is with varus collapse. So this varus collapse is common, or screw penetration is common in 4-part fracture, C type of fracture, or whenever there is medial hinge disruption. So one has to avoid varus collapse. See to it that the C-arm is taken in various views so as to avoid penetration on table. Coming to nailing, the new nail or 3rd generation nail is a pretty good option for part 2 fractures or 2-part fracture. As you can see here, the difference between the earlier nailing, where the nail was put through the rotator cuff, is now the nail is put through the center of the head, passing through the muscle of supraspinatus, so as to avoid cuff problems, as you can see here. And it's a very promising option. The displacement is considered into, or there are 3 different types of displacement. and that has to be taken into consideration while reduction. And a pretty good result can be obtained in a markedly displaced osteoporotic fracture also. Use of same nail in type 3 and type 4 fractures was tried and reported in this series, and they had a revision rate of almost 30%, and there is a significant incidence of collapse and proximal migration of nail in type 3 and 4 part fractures. So it is probably safer to avoid use of this nail in part 3, rather 3 part and 4 part fractures. So to summarize, friends, principles of ORIF: good imaging, good pre-op planning, appropriate patient positioning and surgical approach, anatomical reduction. Achieving stable reduction is the most important thing. There is no harm in docking, there is no harm in collapsing. People have in fact created an osteotomy and put the distal part into proximal part. Getting stable reduction is very, very important. Reduction and stabilization of tuberosities plays a very major role. Implant choice, you could use a plate or a nail, that's your choice. If you are using a plate, medial calcal screws play a very major role. Augmentation of in an osteoporotic bone with a graft is very, very important. And of course, early mobilization and look for AVN plays a major role. Thank you, friends.
Thanks, Vikas. Rajiv, any questions while Dheeraj can share his screen and then invite him?
Yeah, one question was asked from the postgraduate student that in valgus impacted fracture, in a 3-part fracture, if you're fixing it, how to prevent axillary nerve damage?
You're talking of, I think the person is talking about doing MIPO. Am I right? Possibly he's talking of doing MIPO, which of course will be discussed by Dr. Tirachai, but the rule is avoid splitting the deltoid beyond about 4.5 centimeters. Then keep a decent wad of muscle, a decent wad of soft tissues of at least a centimeter or so. Put a finger along the head of the femur, palpate the axillary nerve, go beyond that, and then make another cut, which I'm sure Dr. Tirchai will discuss this at length. I generally do a deltopectoral incision, and then chances of axillary nerve damage are minimal.
Yeah.
That's it.
Okay, Tirachai, you ready? Tirachai, you ready?
Yeah. Can you hear me?
Yeah.
Yeah. Okay. I start now.
Yeah. On.
Good. Okay.
Yes.
Good afternoon. Yeah. Thanks, John, for inviting me to share again my experience of the MIPO of the proximal humerus. Okay, the objective of this talk, the first is the selection of the patients. What is the indication? In the past, we tried to do everything with MIPO, but now sometimes it needs to look and step back what we can do, what we cannot do with the MIPO techniques. I show you the surgical approach, what is the structure at least, how to reduce, and fixation, that's already mentioned by the because of the philos. Yeah, for the indication, 2 parts of the proximal humerus, and maximum for me now is the 3 parts fractures, especially if you have GT, greater tuberosity fractures, and the head and the shaft. This is good indication because you're already on the lateral part of the proximal humerus. The proximal humerus with the shaft extension, maybe without combination of the head. 4 parts for me now is too difficult. to reduce, especially if you have the displaced lesser tuberosities, because it's on the anterior and your incision is on the lateral. It's very difficult to fix or to re-suture the cup sutures to reduce this fracture. So choose the right patient, then it will be easy for you and very impressed for this type of fixation. Okay, just have a look. This is the proximal humerus fractures, right? The patient has a multiple injury, 29 years old. How many fragments? Yeah, maybe you cannot see it well, but if you look carefully with the CT scan, yeah, if you look, you still have a big head fragment here. You see my arrow, right?
Yeah.
Okay. Now, if you look from the lateral, yeah, you can see this is a GT. Yeah, even you see many fragments of the head and the shaft scattered, but the head and the GT is not that bad. Yeah, so if you can restore this anatomical position, then maybe you just bypass this comminuted zone. Okay, now I think this is no choice. Everybody should agree that this is an operative case. Yeah, conservative maybe, but yeah, you will get a very stiff shoulders because of this comminution. Yeah, as I tell you, if you look carefully, if you can fix the head and you bypass the comminuted proximal shaft, then it should be possible to do this MIPO. Okay, the position is depend whatever you want. You can do the B chair, or this is another option. You can swing the C-arm AP and lateral without moving the arm of the patient. It depends on the surgeon preference. Yeah, if you look at this anatomy and the published article of the danger zone for axillary nerve when you do the MIPO of the proximal humerus by using the phylos. Yeah, if you look carefully, this block is the area. Yeah, because the danger zone. Oops, sorry. This is a danger zone. If you look at the anatomical studies, you can fix only 1, 2, 3, 4, 5, 6 hole. Yeah, if you're going down, yeah, this is the axillary nerve that you may hit it. Yeah, so 6 screws on the proximal if you do the MIPO. Okay, supine. Yeah, I always draw the acromion, draw the incision and the axillary nerve. Then the first starter, this is important. You go down on the bone, you see the bursa, then you perforate, you open the bursa, trying to find the rotator cuff. The first sutures, you may not get a very good bite of the rotator cuff or the supraspinatus, but then you make a sutures and then you pull it down, then you can find or can see where is the good position of the cuff sutures that you have to do. Now, this is in a cadaver specimen. Yeah, you see, after you open this deltoid split approach, you will see the bursa. You have to perforate the bursa. I mark this in red, is important. On the bone, that means you have to open the bursa. You have to find the bone, and then you make a tunnel, go under the axillary nerve. If you see the bursa and then you start to prepare the tunnel, then you will be over the axillary nerve. This is the key of after somebody asks this before this talk. Yeah, be careful. Walk on the bone always. Yeah, and the axillary nerve is around, we always said 4.5 or 5 centimeters below the acromion process. Yeah, and the nerve, if you relax the deltoid, that means you abduct the shoulder, then the axillary nerve will be released from the bone. Then you can lift it up with your fingers. Okay, just show you the diagram. After you can reduce, you reduce it. Yeah, you can pass your fingers. You feel this axillary nerve bundle. Yeah, you're going down. If you want to find it more prominent, you go on the back of the shoulder because the axillary nerve is bigger on the posterior than the anterior on the lateral. Yeah, always use these fingers to find. Yeah, the diagram will show you your fingers. If you walk on the bone, then your fingers will lift up the axillary nerve. Now we have to go to the distal incision. Yeah, you have to find the radial nerve because this is very far down. Yeah, if you do just a two-part, it's okay. But if you want to go down, you have to find the radial nerve which lie between the brachialis and the brachioradialis. And then you make a tunnel. You can bypass the bridging comminuted fracture zone, and the plate will lie on the anterolateral surface, lie flat on the anterolateral surface of the distal humerus, and lie on the greater tuberosity on the proximal humerus. Most of the case, the rotation should be okay. Yeah. You have to find the radial nerve. Yeah. If you look, this is the plate. When you slide the plate down, you find the nerve. Yeah. And cook it, and you will see this is the plate, which more anterior to the radial nerve. The pitfall, don't use the Hohmann retractors. I always said, when you make a distal incision, use the Amiri retractors because the tip of the Hohmann can compress on the radial nerve. Just only once, then you will have a wrist drop. Okay, now make a tunnel. This is also important. When you want to make the tunnel from the proximal to the distal, yeah, you have to perforate the deltoid insertion. This is a very tight fibrous adhere to the bone. It's very important. If you make a right tunnel, then the plate can go down and go in the correct direction. So you have to make like an anatomical position, supination of the forearm, and then you make the tunnel straight. If you rotate the forearm, internal, external, rotate of the forearm, the distal will rotate. Then you make the tunnel. Then the tunnel will not in the correct tunnel. And then when you slide the plate down, you have the hole, the wrong hole in the deltoid insertion. And then when you want to fix it, you may create the malrotation between the proximal and the distal fragment. Okay, let's look. Check the AP X-ray. When you make a cup suture, you can see the head is in its position, but you can control this head fragment by the sutures, cup sutures, and then you manipulate, right? Now it's look not that bad with this position, right? Then you fix the head and the shaft, the head and the GT. You check the X-ray. Now it's like anatomical position with the plate and the head. And then you check the lateral X-ray. Right now, the proximal fragment and the plate is almost like a normal position. So this is a very comminuted fracture. You just bypass it, going down in the correct position in the distal part, and then you temporarily fix with the K-wires, right? And this is the final fixation, proximal and distal. Yeah, you will see the gap at this comminuted fracture zone. You can make a little bit shortening of this humerus because 1 centimeter, it doesn't matter for the humerus shortening. 8 weeks, 10 months. Yeah, the range of motion is acceptable, and you see this bridging callus without the bone graft. Okay, now this is another case of 78 years old, 3 parts fractures. Yeah, this is a case that you can fix with the MIPO technique. Again, I show you the deltoid split. Now you see the bursa. Don't make a tunnel. You have to open this bursa on the bone until you see the lateral cortex of the GT, and sometimes you see the rotator cuff supraspinatus on the top here. Yeah. Then you palpate the axillary nerve, abduct the shoulder slightly, and then you make the position. Yeah, sutures, cup suture. You mark the position. Where is the distal part of the plate? The axillary nerve should be around here, right? So we bypass, just make distal incision here. Now, detach the deltoid. Important. You have to detach the deltoid insertion from above or from below. And then you use your fingers to repair the tunnel. This tunnel is under, yeah, the axillary nerve is under your finger, over your fingers. Now you can make this tunnel. Okay, show you how to reduce. You can use the bone hook. You have the cup sutures. Yeah, I tried to use the bone hook to hook it first to correct this varus of the head. And now you see it's not that bad. And then you pull these cup sutures. You can maintain the position of this head into the normal alignment. Yeah, again, or you can use this joystick between the GT and the head, and then you leverage it down. Now you correct the varus, right? And now you reduce, take measure deforming force by using this hammer. Then you pinning. The KY should be from the top down to the shaft. Don't fix it from the lateral to the head because you will obstruct the plate later, right? And then you prepare this tunnel as I showed you before. Yeah, you slide the plate in, you fix to check with the X-ray, right? Use the normal screw to pull the plate like a reduction tools, right? 6 screws is enough. Okay, this is the intraoperative. As you can see, the head is in varus, yeah? And now, after the cup sutures and pull it, yeah, this is the labelage, the KYs in the head. Now, you see the KYs between these two pictures. Yeah, after you labelage, now you reduce almost perfect. You look at the cow car here, right? Now it's almost anatomical reduction. Yeah, and then you pinning from the top down to the proximal medial shaft. And this is the final fixation. Post-op, 5 months. You see, there's still some limitation of the internal rotation. Yeah, in the elderly, most of the cases the limit internal rotation, but she can work, yeah, but not 100% of the perfect function. So in summary, I will choose the 2 parts, 3 parts, or the convolute proximal shaft for the proximal humerus maple. The structure and list, I show you the axillary nerve on the proximal and the distal. If you're going down, far down, then you have to find the radial nerve. However, I will tell you, you need the experience with the open deltopectoral approach first. You have to know where to put the plate in the correct position, how to look at the X-ray, AP, and lateral view intraoperatively. Then you can make this MIPO is possible. But the last one, don't forget, elderly, low demand, osteoporosis, and adoption should be conservative treatment. Thank you very much.
Tirachai, that was great. Do we have any questions, Rajiv?
Yeah, questions again. They have asked about the same axillary nerve. I think it's a learning curve. Dr. Tirachai will explain like which position we should spare not to put the screws. Exactly what is the landmark in which he avoid putting screws. Dr. Tirachai.
Yeah, I think I already showed you, right?
Yeah.
You can fix only 6 screws. That's the most important. And use your fingers to protect the axillary nerve before you slide the plate in. Yeah. And that's the best way to make the abduction the shoulder. Yeah. Abduction the shoulder. And then you have more space to put your index fingers under the axillary nerve.
Yeah, I think you have to be able to feel the axillary nerve with your finger, and the calca screws may be a bit difficult to put in, and you can't put in the jig that you have with the Philos because it's a bit too big to put in through the MIPO approach. So there's another jig for the MIPO approach, but otherwise you do it without the jig. Yeah.
Yeah, with the jig is not, the normal jig is not possible.
Exactly. It's
With the one Vikas showed before, we call the guiding block. Yeah, that one will hit the axillary nerve.
Exactly. Yeah.
Yeah, you cannot use it. And the calca screw, that's why I said it's very difficult. If you want to make a calca screw, you have to open it down, identify the axillary nerve, and then you can put the calca screws.
So if you're really worried or you're not being able to feel the axillary nerve, then it might make sense to extend your incision and actually identify the axillary nerve.
Right.
Yeah, now in some surgeon, they prefer to do, they call the anterolateral approach.
Lateral
That's
approach.
going down and find the axillary nerve. This is the another approach that on the lateral surface. Yeah.
Okay, so we will start some of the case discussions. So Pandey, you want to load your first case, and then we'll have Neerachai's and then mine, yeah?
Okay.
And if there are any questions in between, Rajiv, please go ahead, and any of the faculty want to ask as well, yeah? Ashish, you got anything?
Yeah, I'm keeping a watch.
So are you sharing your screen, Pandey?
Just 1 second.
So while Pandey is trying to get his screen, so Tirachai, the deltoid insertion, there are two ways. You said you release it. The other way is to actually go through the V of the insertion, right through the middle. Have you tried that?
Yeah.
Yeah.
You have to make the arm in the correct position. The elbow should be anatomical position, and then when you make a tunnel from the top down, the deltoid is the V shape. Yeah, it usually is go down to the top of the triangle. Yeah, but try to make it a little bit bigger.
Tirachai, you've got your screen. You want to show your case?
You want to show? I show my case now?
Yeah, you could show your case, and then meanwhile,
John, can you see my screen?
Right now, we've got Tirachai's screen on.
No, that is my screen.
No, I think it's okay.
That's your screen. Okay, fine, great.
Pandey already show it. Okay.
Okay, so Pandey, carry on then.
Yeah. So this is a 66-year-old, pretty fit and healthy lady, plays golf. She's had a fall, and that is the X-ray we have of her, which is, if you just look at the X-ray, it's almost a 4-part displaced proximal humeral fracture. The tuberosity is comminuted. There is a lesser tuberosity, and the head is sort of in valgus impaction. Can I quickly ask some of the panelists as to what they will do for this?
Yeah, definitely. Please.
John, what would you do?
Okay, so
the head is not split.
Okay, so this would be one where I would really worry about how I would fix it if I had to. So I would discuss it with the patient because you have the choice of, because if you wanted to fix it, you'd have to reduce that impaction and you'd have a very small head fragment. And then getting it to getting good fixation on it might be difficult. So I would consider both options, but talk to the patient and maybe try to convince her for conservative treatment. Yeah.
Okay. Ashish, do you?
Yeah, I think this is one of those proffer cases where you could go both ways, and I would sit down and talk to the patient. The pros and cons of
If you
both
want to
options are.
fix it, what will you fix it with?
Yeah.
I would plate this for sure if I do really go in. My biggest concern is the tuberosity fragments. There are multiple of them. And in order to get them good rotations, I would want to ensure that the GT goes back into its original place, both the GT and the LT.
Right. Dr. Tirachai, what would you do?
Yeah, I will fix it because
Fix it with what? Sorry.
The head is rotation almost 90 degrees.
Yeah. What will you fix it with?
The plating.
Plating. Okay.
Yeah.
Yeah. Vikas, what would you do?
Yeah, I would, as everybody has said, we will discuss with the patient. Finally, in our country, patients say, you decide, doctor, what is to be done.
Yeah.
So I would open reduce with a deltopectoral approach, try and get tuberosities properly, lift the head, will possibly put some bone graft, either patient's fibula or allograft is available, because I'm sure once I lift it up, there will be just an eggshell. So I'll support it and with a plate. Maybe after today's your presentation, I'll start conserving these fractures, but at least before, as of now, I'll fix this.
Yeah. So, wait till Ashish's presentation, then you'll replace everything.
Pandey, would you think of something like the Resch technique in a case like this?
Yeah, so I was just coming to that. So I gave the choice to the patient, not because I knew in my heart that this is not exactly the best case for non-operative management.
Yeah.
But I thought it is so difficult. I was thinking of replacing it, doing either a reverse shoulder or a hemi-arthroplasty, but I thought the patient was quite young. Fixation is an option. It's always an option, but I was a bit worried about the size of the head, as John, you rightly pointed out. So I gave the choice to the patient and he said, do you really think you can treat this without surgery? So I said, I'm not so sure. It looks pretty bad, doesn't it? He said, yeah, it looks very bad to me. So what do you think? I said, okay, let's do something. So initially we thought we'll replace it. But then as I'm getting older and I'm thinking, oh, I got a bit cocky and I did this. So I did the Resch technique.
Yeah.
And I thought I got a reasonable head and the tuberosity is underneath the head and it's in the right place. And after about 6-7 months, the fracture healed. So I thought, well, I've done brilliantly there. And I was even more cocky and I showed these couple of x-rays in conferences and showed my friend how brilliant I've become. So everything was going very well. But this patient, the problem in NHS is they always come back to you for follow-up.
So this is not the classical Resch technique, though.
No, it is not classical Resch technique, but this is the technique which I have developed over the years. And we have published this in JBJS and now in shoulder and elbow also. So this is the most important screw because it provides the buttress for the head and keeps the tuberosity where it should belong. And then everything has got some hold. So everything, you can mobilize them at about 2 to 3 weeks, but not immediately, but gentle mobilization. Anyway, I was very pleased as to what has happened. So as somebody has said that nothing spoils your results than a good long follow-up. So this patient came back at about 18 months to me saying, Doc, it's my shoulder is getting worse and I'm getting some pain now. So this is the X-ray I had. We did an X-ray and we did that and we thought, oh, the head is slowly disappearing. So I thought maybe his restricted movement is there. So I removed these 2 screws because I thought they're backing out. And this is a good thing about this technique is that screws back out rather than go into the joint. So I could take them out under local anesthetic, but then it continued and then you see it's completely destroyed. And the screws are in there. So now I'm left with very little choice. And then I had to go and do a reverse shoulder arthroplasty because this is what I wanted to do in the first place, but I had to do it maybe, so I bought about 4 or 5 years. But you see, the most important thing here, I'm sure Ashish will turn because there's no bone left, I still could get some of the rotator cuff and attach it around the prosthesis. So the message of this is that management decisions have to be very good. Just because you are good at one technique doesn't necessarily mean you can apply that to every case. And in this case, a proper evaluation of the fracture was extremely important. And if you look at the CT scan, the head is very small, the tuberosities are almost shattered, and there is a big medial gap. So the blood supply to the head was very poor. So now even if you did a plating with bone graft, I don't know whether you would have salvaged that head in the long run or not. So sometimes the initial operation is extremely important. However well it's done, if you don't evaluate the fracture and assess whether this head will survive or not, you may end up in a bigger trouble.
Okay, great. So should we have Tirachai's case on?
Yeah.
Tirachai, you ready with it? And any questions in the meanwhile, we can keep taking on, yeah?
Yeah, one question to Dr. Pandey.
Yeah.
One question to Dr. Pandey, that can we would have fixed with K wires, percutaneous K wire fixation?
No, I have given up K wires because I put the K wires initially to reduce everything, but I substitute them with cannulated screws. So I put cannulated screws and take the wires out. Wires sticking out of the deltoid and skin is not good. You get infection, a lot of fibrosis, and you lose a lot of movement. And the wires migrate. Screws migrate too, but wires migrate more. So I will put the wires, but before I come out, I substitute them with cannulated screws and then take the wires out. And the screws get a better hold than wires, in my opinion, and they are easily removable in the later on, and I can mobilize them at 3 weeks. I don't mobilize them immediately because this is not rigid fixation. So you mobilize them at 3 weeks gently and then gradually increase. But don't leave wires. I think they cause more harm than good.
Right.
Okay, so Tirachai?
Yeah. Okay. A short case.
Yeah.
This is a 78 years old female, just a simple fall. This is the first X-ray. Yeah. And what is the treatment option for this case? Okay. May I
would treat this one non-operatively, Thira.
Yeah.
78-year-old. I think the tuberosity is in a reasonable place. The head is slightly tilted, though the shaft is, everything is nearly not bad. I would treat this non-operatively, or at least give the choice strongly to the patient. In a
you see the shaft is shifting on the medial.
Yeah. So anyone else? What about Ashish?
Yeah, as I said, it's the tuberosities that win matches. If the tuberosity is there, it's unharmed. That means her cuff structure is good. And at 78, you should give her that option. But I would monitor her very closely.
Yes,
so
absolutely.
If I observe these patients, I would do X-rays every week for the next 3 to 4 weeks.
Absolutely.
Would you fix that?
Yeah, I'll also conserve.
I mean, is this
As
a
Ashish said,
this is post
even prior to his talk, I think I would conserve.
Okay, good. Yeah.
Okay, now the follow-up is a 1 week follow-up.
Right.
Did you change your mind?
No, this is
Holding
looking
on.
good. It's looking good.
Holding on, yeah.
The lateral looks good.
Lateral looks very good.
And even here, there seems to be good. It is sitting quite well.
Yeah, it seems
So
to be.
hopefully,
The contact surface is around 40% now. It's okay?
40%, which surface are we talking, Dr. Tirachai?
The contact surface of the fracture between the proximal and the distal.
I would say it's a bit
It's
more than
40%. More than 40%.
Also, the whole arm is
Almost 70,
slightly internally
80%.
rotated.
So what I guess on the AP, that's close to maybe 40–50%, yeah? If you just look at the AP X-ray, but that may be deceptive.
Yeah, if you look carefully, the diagnosis of this case is there are two types of this proximal
valgus,
humeral fracture, right? In this case, the head is in valgus position.
Valgus, yeah, that makes a difference.
Yeah, and the GT is below the head. This is the important configuration of this fracture type. Okay, I show you more. Conservative treatment. Yeah. And this is 2 weeks now.
So it's reduced to some extent just by gravity.
Yeah.
If it is in this position at 3 weeks, it means it's a stable configuration.
Yeah. Definitely.
Yeah, okay. I show you more. Now it's 3 months.
Right.
How you can make it better than this?
No, you cannot. Even with MIPO technique, you won't get better than this.
Yes, I agree. because this does the spontaneous reduction. If you have the valgus 3-part fractures, because the head tends to be moved in varus, right? And it's automatic reduction. We call it spontaneous reduction. So I think this is a good option for conservative treatment. And I show you the result, yeah, from this first X-ray and the 3 months X-ray. Yeah, this is the head is moved a little bit down and the shaft is varus. The head is go slightly varus, so it's like compensation to normal position. And
Dr. Tirachai, can I just ask you, when did you start mobilizing this patient?
Yeah.
As I do like your recommendation or your program. Yeah, around 2 weeks I start pendulum with the sling. Yeah, 3 weeks, 90-degree of abduction, because the fracture now is like a sticky a little bit. Yeah.
So, but that's passive abduction or active abduction?
It's a passive abduction.
Passive abduction, yeah.
Yeah, yeah. Now, this is a function at 5 months.
Wow.
Yeah,
You can't tell which one is broken.
Nobody can do it better than
Absolutely.
this. So don't forget your root of the treatment. Huh?
Exactly. I think this is something which is important to bring out, that many of these fractures can be managed conservatively. Yeah.
Especially with AC, as they say, after Corona.
Okay, great, Tirachai.
Okay,
so
thank you.
To my case now. Have you you stopped sharing?
Yes.
Okay, so I'll put mine. Hopefully that's there. Oh, this is not the one. Sorry. 1 second. I'm going to have to go to my file.
So in the meantime, what the Tirachai presented his case, there is one question from Gerald Gonsalves that please explain how you managed to avoid the radial nerve distally to Dr. Tirachai in his MIPO technique presentation.
Yeah, yeah. You mean the distal part, right?
Yeah.
Yeah.
How you avoid radial nerve?
You have to find it in the distal.
Yeah.
You have to find the nerve, and between the brachialis and the brachiolaris, it's like you explore the radial nerve in the lateral of the arm on the distal part.
Right.
You have no choice. In the past, I do with the anterior approach. Don't try to see the radial nerve, but I make a brachialis split in the distal part, and then I pull the brachialis down. But the problem is the muscle trying to push the plate to the anterior, right? And it's very difficult to fix in the correct position. So now If I want to go down in the distal humerus incision, I find the radial nerve, and then it's easy to retract the nerve to the posterior, you retract the muscle to the anterior, and then you find the bone. Yeah, more easy. Yeah.
Right.
Okay, so
Okay.
I think.
Thank you, sir. So, yeah.
Can you see the
Go ahead.
screen? Okay, so this is
Yeah,
a
we can.
old gentleman who, interestingly,
you make full screen, please. You make full screen.
yeah, is it full screen?
No, it
sir.
isn't.
It isn't. Well, it's full screen on mine.
Go to slideshow, sir. Go to slideshow.
Go to slideshow.
Slideshow. There's no slideshow.
On the top, sir. Besides animation, you have slideshow.
I don't have animation here.
File home and animation slideshow.
Let me cut it. Switch
The
this.
top menu, you can see that, sir.
Where?
Or
The
choose
top
the
menu-
bottom toolbar as well.
Yeah, as well.
Can you see the bottom toolbar? There are
Yeah.
5 icons there.
Yeah, let me just first minimize this one. Now, which one do I resume?
Put the second slide, sir.
So on the bottom right, you have this. Yeah.
Which one?
No, John, this is not working.
No,
Go
no,
back.
it's not working, sir. Go back.
I think I
sir.
have to stop share and start again. 1 second.
Yeah.
Yeah.
Okay, and I would need to shut off that one extra presentation.
Open the file first, sir.
Yeah, it's open. I just okay. So that's open now.
And then share the slide.
Just give me a minute. You can take some more questions in the meanwhile.
Right. So, one question to Dr. Agashe, that you please explain the 3 pillars which you have said, whether it is the GT, LT, and Calcar. So 3 legs you have said. So the question from Janki Saran Badani, sir, what are those 3 legs? Dr. Agashe, please. Is Dr. Agashe here?
He's not, but let me speak on his
Uh,
behalf.
I have
Yeah.
unmuted him. He was mute. I have unmuted him.
There you go.
Okay.
Vikas, sir.
While Vikas is answering, is the full screen on
Yeah.
now?
Yes,
Yeah,
yes.
full screen is there. So
Yeah,
is
will
Vikas
answer the
answering?
question? No.
These
So-
3 pillars are going to be the calcar, the lesser tuberosity, and the greater
And the greater
tuberosity,
tuberosity,
just for the
Yeah,
delegates.
right.
Okay, so this is interestingly a patient who, when I was out somewhere and this patient was put up for surgery for his tibia. Okay, so he had a 3-month-old injury. It was open fracture, which was initially treated with an external fixator, and then that was removed at about 4 weeks, and then he was put into a cast. The wound had healed, but the fracture had not united at 3 months, so he came to us, and he was actually put up for surgery. And I saw him on the ward round just before surgery. And of course, this is not what we'd be talking about in a shoulder, this thing. So he also had an injury to his left shoulder. When I asked him, I was talking to him before his surgery. And apparently he had a dislocation of his left shoulder, for which he had a closed reduction, was immobilized for 3 weeks and then mobilized, but was having difficulty in lifting his arm. And these were his shoulder x-rays at that time. So anybody from the panel would like to comment on the x-ray?
So firstly, John, that's not a true AP X-ray because that tends to be deceptive. So
Okay.
my recommendation is that please make every effort to get a true AP and an axial, because this one is steep in internal rotation, rather deceptive, and so it doesn't give this information. And when you're in doubt, just go repeat the X-ray. If not, then get a CT scan done if you think
Yeah.
patient is not able to
Okay.
position.
But if you look at this X-ray very carefully, what's this here? Can you see the
You
arrow?
see, please. That's
Hmm.
yeah. And you
It's
see
a-
on the head, the lateral of the head is like something missing.
Yeah. So this is interesting. Say so easily missed if you just look
Yeah.
at casually. And
Is that a lesser tuberosity fragment?
well, if I lesser, no, Okay, so luckily he had his old x-rays. This was his original injury. Okay, so they'd done a closed reduction. And this is what most of us would do, I guess, would do a closed reduction. And that was the post-reduction x-ray. And again, you can see, if you look very carefully, this is the fragment sitting here. Okay, that's the graded tuberosity. And again, it's quite easy to miss. I mean, and so the person treating him decided that this was okay, and there was no significant displacement for the tuberosity. And it's interesting how it looks. So obviously then they got the CT done, and it was clear that this fragment sitting up here was the tuberosity fragment. And he was having difficulty. He couldn't move his arm up. And so we did the tibia, but then we decided that something needs to be done. So anyone from the faculty would volunteer to tell us what we would do?
How far back from the injury was this?
3 months from the injury.
So 3 months is very dodgy. I get more grief from greater tuberosity neglected than proximal humerus neglected, which you can conserve, as Pandeyji has clearly said. And it's iffy. There have been times when I've gone in 3 months and managed an anatomical fixation. And there have been times at 3 months that it just wouldn't budge. And the repercussions of a GT not being there is game over. It's all or none, because then they cannot get any kind of forward flexion abduction at all. So it's very imperative you do a lot of releases. My preference is arthroscopic because that's my DNA and that's how I think. But I mean, I get much better access medially, so I can do a full-blooded release because that GT sits on the posterior superior glenoid. So I have to do a lot of release, arthroscopically use the radio frequency, and then manage. My exception has been a 1-year-old that I have managed, but I also have 3 other patients at 3 months that didn't come out completely, and we had to medialize that fragment.
Okay, so Pandey, anything to add to that?
Yeah, I think it's more like a cuff tear, isn't it? That tuberosity is broken, so it's taken the cuff with it. So you have to do something to bring the tuberosity somewhere close to where it was. And yes, as Ashish said, you will require extensive release, and sometimes you may have to put the scope from inside and release inside, and then come out and do a mini open, release it, pull it back. The problem here is the original hole gets filled up with fibrous tissue and scar tissue. So sometimes you cannot find the gap, or once you've taken the scar tissue out, the gap is so big and the small fragment is so small, so it looks like a big mismatch. But I don't think we need to worry too much about the mismatch. Sometimes you can even make the tuberosity bone fragment slightly smaller if need be. But here I have failed to put screws. If it's that far down, I will avoid screws and I will use anchors, 2 or 3 anchors, and try and fix it like a rotator cuff tear. Because the screws, as I said, there will be a big mismatch, and sometimes the screw is not properly attached distally, it starts to back out.
Sure.
So those are the few things. I would use anchors to fix this rather than screws.
Okay, so anything more to add from either Tirachai or Vikas? Or
I may try to use both.
Sorry?
I try to use you have to make a split deltoid, mid-deltoid split. This means slightly posterior.
Yeah, so we are the open surgeons, Okay.
Yeah, I do the open surgery.
The coronal X-ray is usually very deceptive because it looks medial, but it is in the nature of the GT to displace more posterior than medial. So you really need to hunt posteriorly for this.
Sure, I agree. So we went so that's where it's lying if you look at the CT scan, and now you can see the defect here very clearly, So where it's come from. So we went open, transdeltoid, and we had to fish it out. Interestingly, it was quite mobile, this fragment. Okay, once we got it, we hooked it out from behind, and then with some release, we could get it down. And so what we did was we actually put a screw in it and also put in suture anchors and multiple sutures to repair, also suture on the rotator cuff, which was attached to the fragment, but there was also a little bit of a separate fragment there, which we sutured on with the thing. And that was our post-op X-ray at the end of that. Okay. Now, okay, so that's what we were able to achieve. This is him in one of the follow-ups at about, this was 1 month. And then luckily we got a longer follow-up on him at 3 years, 9 months. And somehow these things held on and he ended up with a fairly good function, not 100% normal, but a fairly good function. So I think some of these even late you can reconstruct. But the good thing about this particular one was it was literally an avulsion of the tuberosity with the rotator cuff. So it didn't get plastered down everywhere. Although we did have to do some releases, it wasn't very extensive release that we had to do to bring it back into place. And the fragment was still reasonably in good shape to be able to put a screw and add on a suture anchor to support it.
I think, John, if I just mention here, if you look at this X-ray, your screw is here and the tuberosity is mostly held by the anchor.
No, but this tuberosity has a fragment going down there.
Okay.
I put it down there, yeah.
And the good thing is your screw is going right up to the calca, so it's got a better hold. Whereas if the screw was short and there was no anchor, this may have been pulled
absolutely off. Yeah. Okay, so any questions? Otherwise, we can go on to Ashish.
Yeah, one question to Dr. John. Dr. Esen Sarraf has asked that how to reduce the GT and LT in an old case of 4-part fracture of proximal humerus.
Okay, so I think we'll talk about that in the in my later talk.
Yeah,
okay?
Yes.
It's difficult. I mean, the longer it is, the more difficult it is. But we'll discuss it after that talk. Yeah.
Yeah, sure.
Yeah, Ashish.
Right. Have you got the full screen here?
Yeah.
Yeah, lovely. So after those excellent 3 talks, let's move to a little more complex schedule where we're going to talk about shoulder replacement. It's a shocking slide, but it's true because the shoulder replacement as it is had a lot of bad press, but most Europeans are reluctant to do a hemiarthroplasty now for proximal humerus fractures, and there's a reason to that. But the whole thing started about the reason hemiarthroplasty came in was there were a lot of reports of complications with lock plates, and I think the lock plate has made everything look easy. Till the lock plate came in, it looked like we didn't have a good implant. So most proximal humerus fractures were being conserved 20 years back. And then suddenly lock plate has given us a feature where we are empowered. And so they've been done left and right. Also, there is a confusion between fracture healing in an anatomical position and the restoration of function. And there are 2 things that I would emphasize today is you have to look into my talk from a perspective that we are treating the elderly patient. You cannot extrapolate these findings that I'm going to put forth to the younger patient. Number 2, we're largely predicated on restoration of function, and that is what we wish to send home the message. Now, for a hemiarthroplasty to work, you cannot use a monoblock stem and just put it in and expect it to work. It is not like a Austin Moore prosthesis. The shoulder is very complex, and that's why it gets a lot of bad press because it's very difficult to replicate native shoulder anatomy. To do that, you need to think in a 3-dimensional manner. And if you can achieve a 3-dimensional reconstruction and you can translate that into an ideal GT healing, I'm not saying fixation, an ideal GT healing, you will achieve that if you position the height of the prosthesis correctly and you achieve the perfect version. And there's a lot I can talk about version as such. Even after doing that, if the GT doesn't heal, it'll be game over. And that's why many surgeons are reluctant. The caveat here is that the results of primary hemiarthroplasty versus a fixation, let me try fixation. If it doesn't work, I will offer a hemiarthroplasty is not a good policy because then you're dealing with a late fracture with a lot of soft tissue damage, and those results cannot be as good as primary hemiarthroplasty. So you need to take a decision on day 1. And obviously there are many fractures in the gray zone where you're undecided whether this will work or that will work. And most of the times when I'm doing a hemi, I'm actually planning to do a fixation and I keep the hemi on my back table. I don't think it's fair to go on a table and say that I can't fix this, it's terrible, but I don't have a hemi, so I will put this into some kind of fixation. So you need to be prepared for both. The problem is the hemiarthroplasty done for osteoarthritis is remarkably different from doing a hemiarthroplasty in trauma. And the results are also equally different. The complication rates are much higher in trauma. Number one, because the proximal humerus is exploded, there is no landmark there to decide what is the version, what is the height of the prosthesis, what rotation should I put that in. The biceps is unreliable. Often that is exploded, the groove of the biceps. You can use pec major as your height according to Murchowski's paper, but it's again a soft tissue, unreliable landmark. The version is crazy. Surgeons go wrong in humeral version in osteoarthritis, although they have GTLT in position. And in the trauma, you can imagine that it just looks like a round cylinder looking at you. And I've had to revise patients, they were put in 90 degrees, completely wrong side, and they just dislocated the second day. You need to recreate the posterior and lateral offset. You must ensure that the axillary nerve has not been involved. If there's an axillary neuropathy and you end up doing a reverse shoulder replacement, that could be a little sinister, and you have to be very cautious about that. You must be sure that the rotator cuff status of this given patient is appropriate in order to do a hemiarthroplasty for these patients. Unfortunately, most of these patients are fairly young. They're not like your arthritis patients. So patients like this who have a seemingly innocent fracture, looks three-part, looks fixable, and you go in and it turns out to be osteoporosis because they are rheumatoid or they have comorbidities and the whole eggshell is hollow, and those are where you get caught out. A conventional 2 and 3-part fracture can be fixed very nicely with a lock plate, and you can come out of that winning 9 out of 10 times. There's no question. But this is a nice paper from John Kontakis, and he said that in his patients, he'd had 11% GT complication, 7% proximal migration because the GT did not heal in a hemiarthroplasty. And a hemiarthroplasty without a total shoulder will inevitably lead to medial erosion of the glenoid eventually and cause medialization. So this is important to understand. And the rehab program for hemiarthroplasty is quite challenging. This is Brunner's paper, European multi-center study. Avascular is not a big deal with proximal humerus fractures, 8%, and most of them will revascularize very nicely because there's a very rich blood supply in the proximal humerus. But this paper across all of Europe has explained 25% reoperations, 45% complication rate, especially in the elderly. So we are dealing with elderly population and we are dealing with 70 and above. The quality of tissues, the quality of the bone are all compromised. And as a surgeon, I can't leverage that. So, and at the same time, we must understand that I think there was a very important point that was made by Dr. Agashe, that you must leave your screws 10 mm short of the subchondral bone. This is not DHS. You can't put it subchondraly because screw penetration, unfortunately, has been the biggest malady of a lock plate fixation. And 22% is too high a rate, and it goes unrecognized because the lateral x-rays are not done. And these patients unfortunately come to me after a year or 2 years where the entire glenoid has been eroded, and it's unnecessary to subject these patients to a reverse shoulder replacement, even though the fractures healed adequately. A little bit about the axillary nerve. Do be very careful. I'm a great proponent of the deltopectoral approach because even if there's a 1% risk of an axillary nerve going wrong, it's a disaster for that patient because it's all game over. If one does a lock plate, it goes wrong, it malunites, undergoes a non-union, I still have an option of revising that with bone graft. I can do a hemi or do many other options. If the axillary nerve is gone, these patients come to me like this gentleman was operated at a Premier Institute, Haryana, and the deltoid split approach established axillary nerve palsy post-operatively. Prior, it was good. Long screws, the screws are proud. You can see they are cut out completely, the damaging glenoid. He's had 3 surgeries before he came to me, and none of the surgeons handled the screws because these are plastic surgeons. They thought like a plastic surgeon. They continued working on the soft tissue and the axillary nerve, and poor fellow has come with complete arthritis now. So we had to go in, and with Anil Bhatia, we went in, explored the axial nerve, we decompressed it completely, did a SOMSAC for him, and removed the implant unnecessarily. This is a very interesting paper, the one on the bottom, Westphal study. I would highly recommend you read that. And in their 40 patients, all of them deltoid split, they did EMGs for all those patients. They had a 10% incidence of axillary nerve damage. So do be very careful if you're not well versed with anatomy, if you don't have the experience of Tirachai, then be very careful. Just stick to your deltopectoral approach, because you don't want to flirt with the axial nerve. Is the most important part of that anatomy. Now, this was the paper that spoiled everything for hemiarthroplasty. Pascal Boiler study 2000, and Pascal is one of the senior most surgeons, extensive shoulder experience, and 23% of his patients had a detachment of the greater tuberosity, even after an initial correct positioning. So even if you do this good on the day one and it displaces later on, especially in females above 75. So do be careful about this. And that's why, unfortunately, France and Germany, they just stopped doing hemiarthroplasty. They would directly do a reverse shoulder for these patients. So these are three different scenarios of all my patients. You look at number one scenario, of course, this is a complicated, neglected posterior dislocation. We were compelled to put the stem down because all the tissues were too tight. There was a paper thin subscap. Number two, I had positioned the GT perfectly well. This was a senior 65-year-old Parkinson's patient. And 6 weeks later, prior to starting rehab, the GT just underwent osteolysis because the GT derives its blood supply from the marrow. If the GT does not integrate and heal, it is just going to undergo osteolysis and disappear. Number three is the ideal scenario. When you put your GT in there, it should look that it belongs there. And that's very important to understand. That looks like it belongs there means that it should be like a watertight closure. Number two, the peak of the head of humerus and the GT should have an 8 mm difference between them. And at the same time, you must ensure that it's sutured. We cannot use screws and wires in there. I use number 5 Ethibond to fix these patients. That's very important. Now, version, there's a lot of chaos about version. We are conventionally told to put in 30 degrees version. I completely, I'm against that. We published this paper in the Journal of International Journal of Anatomy. And amongst the 65 cadavers we did, the largest variation on all the morphological sizes were on versions. And they varied from 18 degrees to 55 degrees. Most of the available instrumentation allows you to choose 20, 30, and 40. That's it. So you need to be on the top of it. If you do a wrong version, as you see in this diagram here, you will notice that even if he rotates it gently, that GT is going to come off completely. So that is very important that you understand what is a version, and you would need to be familiar with anatomy. There are a number of jigs available for the shoulder replacement sets. They're very complicated, tedious, and difficult to use, especially in small incisions, which I do. So instead, I prefer to use a trauma stem. So if you're doing a hemiarthroplasty or osteoarthritis, you can use a conventional polished stem, is fine. But when you're doing trauma, because there's explosion, because you want the GT and LTs to sit in, you must have a trauma stem. By trauma stem, I mean that this is a conventional reamer, whereas this is the reamer from a trauma stem because it has these nice 4 markings. We helped develop this design with Evolutis, and I was instrumental in designing this design. And these are the same designs that are replicated here on the final stem. The final stem is smooth distally, but proximal 2/3 is hydroxyapatite coated, and it has a honeycomb shape here. So it creates a friction fit between the tuberosities. So it allows the tuberosities and keeps them there. That is very important. The screw holes, the thread holes for the sutures are not exciting. I rarely use through the stem. I prefer to pass the sutures through the bone because I want the GT and LT to heal with bone. But this one is important, and that's called as a recessed hole for the circular suture. I'll come to explaining that in a later few slides here. Once you're done and you're finished, you must repair GT to LT, GT to shaft, LT to shaft, and the GT to LT as well along with that. So it has to be a robust fixation. We call this the parachute closure, so that you have a watertight closure, which means that you've balanced the shoulder correctly, the soft tissue balance is adequate, your sizing has been perfect, you've not overstuffed it, and your soft tissue repair is good, so that patient is likely to do well. We lost about 3 greater tuberosities. I have problems with 2 other patients. And since then, we've improvised the technique. I'm going to share the pulse. The 2 things that we did to change our practice was, number 1, this was the Mark Frankel Neer Award paper. We started using 2 circlage sutures, number 5 or some of the fancy fiber wires to wrap around in an orthogonal plane and in this fashion. And we use the knee snot. So we published a study on the knee snot, and we've proven that the knee snot is much stronger than a simple surgical knot. And since then, touch wood, knocking on wood heavily here, we've not lost a single tuberosity. But that means that there are almost 12 sutures in there. You have to be a master of suture management at the same time. The one other thing we did with the company was we demanded metal spacers. Often they'll give you these plastic spacers, and when you put them in, it doesn't give you the configuration. You don't know whether GT and LT are sitting in their ideal position. But when you use metal spacers, because you need at least 4 or 5 different sizes, then I know that once I have fixed my GT in there, that GT with reference to the top edge of the humeral head gives me an accurate establishment. This is an offset SEM. This lateral view is very critical. And I can see that the anterior offset is marginal, the posterior offset is significant, and it is covering the head ideally, which means that I think I have balanced the shoulder appropriately and chosen the correct sizes. A little diversion here. Sometimes you have a 60-year-old lady and you're reluctant to a hemiarthroplasty because the literature is stacked against you and it looks like a hollow head, split head, and so we go in and we do this intramedullary device. So this is in between a fixation and a hemiarthroplasty. This is just unique. It's a simpler technique. It takes 40 minutes to do it, but you must apply it in an appropriate patient. It's done through the deltoid split approach. And since it's intramedullary, it prevents the varus. And there's separate head fragment, which is a staple. There's separate shaft stem. And then you mate the 2, and then you can actually bring about reduction by a ratcheting mechanism. Equally important, whether you do a lock plate, hemiarthroplasty, just unique, or reverse shoulder, you must repair the greater tuberosity back into position, because again, I would reiterate, it's the greater tuberosity healing that wins matches, not the repair. This is the lady, and you can see this. So this is 2 years after surgery, and she's done exceedingly well. Not only is she able to do anything, she's actually a yoga teacher, and it was very important for her. And she made a request that try not to do a replacement because it will stop my yoga classes, because that's her breadwinner. So it can be well. This is a processes that can be revised in case goes wrong, and you can still retain the stem. But hopefully, if you planned it well, you must not need to revise these processes. This was our paper about our results of hemiarthroplasty in the Journal of Orthopedic Surgery, 2011. We had about 56 patients. This was a younger group, proximal humerus fractures, 3-part and 4-part. And we had a decent result, average 111, average forward flexion was 143. And we did not have any difference between 3-part, 4-part or split head fractures. Average UCLAs were 28. And there was no significant difference outcome between the fracture types as such. Now, you must understand there's a third option here, which is a reverse shoulder replacement maintained only for the very senior elderly 70+ patients. But it's important to understand what are the differences between hemi and reverse. The reverse is exceedingly better in osteoporotic patients who do not have a greater tuberosity or who do not have a rotator cuff, in which case their function will work even if the cuff is absent. So their flexions are better, their abductions are better, the rotations need not be better. If a hemi goes well and everything heals up, your rotations are much better on hemiarthroplasty. But the reverse shoulder is a fail-safe. Even the tuberosity doesn't integrate, your patient is still going to do well. When you're dealing with 75 and 80 years old, you just want to do one operation and you don't want them to come back for a resurgery. Rehab is easier. You're dealing with very elderly patients. You don't need a classy rehab program like a hemiarthroplasty where it has to be spot on. Of course, the costs are higher. The complication rates are much higher. So you need to be really on the ball to be able to handle a reverse shoulder replacement. So in short, hemi is tuberosity dependent, the reverse is tuberosity independent. The hemi by itself without glenoid resurfacing is likely to cause medial erosion. In my practice, it takes about 10, 11 years to do that. The reverse is surfaced on both surfaces, so it's not a problem. 10-year results after 10 years, because of the aging and the rotator cuff dysfunction, results for both hemi and reverse are supposed to drop down according to the Shukla's paper in Journal of Shoulder Elbow Surgery. This one is hot off the press. This is Barlow. This is from Joaquim Sanchez Sotelo's Mayo Hospital, very high-end tertiary referral center. And this was very recently published in Journal Shoulder Elbow Surgery last year. Average age more than 60. They had about 176 patients, 44% complications requiring resurgery, 34% requiring resurgery. And those who are above 80 had a 50% failure rate. The reason for that is the tissue and the nature of the bone and the absence of rotator cuff in these patients. And that's why you want to do only one operation. So you can choose on doing only a conservative operation, or then if it's a 3 and 4 part dysfunctional fracture, I would rather go in for a reverse in this patient. This is a gentleman who's a multi-comminuted, many fragments, split head, came to us 6 weeks from Indore after the injury because nobody was operating him. He was a politician and we had to do a hemiarthroplasty. Sometimes when I'm doing a hemiarthroplasty in trauma, I would cement this. This is an older generation's stem, but conventionally, although I would choose uncemented, but in trauma, it is very important that you cement the distal part. Now coming to this lady, 81-year-old lady, 3 parts. She's an active lady, drives her own 2-wheeler. She works at her son's factory, manages all his accounts, very alert, very intelligent. And she had this 3 parts. She's 80. The temptation was to leave her alone, not do anything, but it was important to give her function. She was so intelligent. She questioned me for about 15 minutes and told me what is the guarantee that I would do well. I have to have my function. She lives alone. So we counseled her and offered her a reverse shoulder replacement given her osteoporosis and a 3-part fracture. This is a uncemented reverse shoulder replacement we've done. We've managed to restore her ADLs. We have got a 3-year follow-up on her. And if you can look at her range of movement, this is what I'm trying to incline. It's perfectly okay for somebody to treat that fracture without surgery or do something minimally invasive. But as I said, we are heavily leveraged on restoration of function. And when you can see she's so much with it and she's a regular follow-up. In fact, she's due April every year. And we've managed to restore almost 80% of function. And that's the nature of the reverse shoulder, which is very forgiving. If it's done correctly and the tuberosities integrate, you actually get back your significant amount of rotations. And but of course, you have to be very sure that the complication rates are not higher because it's a slightly more complex surgery. It deals with very frail elderly patients, and often they have comorbidities. But the whole idea is not to subject them to revision surgery and to restore their ADLs. You can't fault us on that for having done a reversal on this patient. So finally, in conclusion, you must remember now I have put forth that there are several options. I've eliminated nail. I'm not too fancied about the nails, though I have used them seldom. You have a plate, you have a just unique intermediate device, you have a hemiarthroplasty, and you have a reverse shoulder. And often there are gray cases where in the gray zone, you're not sure whether you need 1 or 2. You could use either of them, provided you're sure you're restoring the function and not creating more complications for a second surgery. But often we tend to forget, and I completely endorse Pandeyji's talk here, that there is another beautiful option. By beautiful, I mean the sling. Don't get distracted here, but it's often an option when you do this, and we do a lot of patients who are conserved, but do be careful, mobilize them early, as Panditji said, but do serial x-rays on the conserved patients every week. So finally, in conclusion, I would like to say that number 1, be careful that you understand the nature of the disease. It's a very complicated fracture. The point is, you could do a very good job on an x-ray, but you may not restore function. So you must separate the wood from the trees and not show x-rays, but give the patients their function. And each patient is different. You can't use the same hammer to treat every nail. So Along with that, you must also understand that whatever you do, whether you are GT fixation or you do a plating or a hemiarthroplasty, the greater tuberosity is got to heal in its native position. Younger patients, you have to be careful if you're doing a hemiarthroplasty. When you're using a hemiarthroplasty, definitely use a trauma prosthesis, but understand the native version and morphology of the shoulder. Results, reverse shoulder replacements are better than reverse shoulder. The reverse shoulder for elective cases, non-trauma, are far superior than reverse shoulders for proximal humerus fractures. So you must be careful. You don't treat them as if I'm going to get them back their full movement as such, but reserve them for the very elderly, frail, fracture dislocation patients as such. Thank you very much for your attention.
Thank you. Thank you, sir.
Okay, so do we have time to continue, Rajiv?
Yes, sir. We can continue.
Yeah, we have time. Yeah, there is one question from the viewer to Ashish that like in a impression fracture of head of the humerus, what is the indication of primary arthroplasty?
See, there are a lot other factors, Rajiv, that you need to consider. Is what is the incidence of impression fracture? If there is that impression fracture associated with the posterior or anterior dislocation, if it is within 5 mm, the unsatisfactory position, I would feel free to conserve him. And if it is significant and if it's in a very young person, then I'm very reluctant to replace them. So there is another technique for these patients where you can go distally into the humerus, where you usually put your calcar screw and just make a drill hole like you do for an AVN and impact the bone out, and the impression fracture can be pushed out. So then you're getting the cartilage, you're not voiding the joint, you've not opened the joint. And then, of course, you'll have to bone graft the track in there. So that's a via media for the younger patients. Most impression fractures that are less than 1/3 of the size of the head, I would feel free to leave them alone, conserve them. And if they were to go bad, I can always replace them at a later stage without compromising the result.
Yeah, thank you.
So there is one case from audience to show for opinion. Can I share that case, sir?
We'll do it at the end, okay?
Yes.
And we do that at the end, if that's okay?
Yes, sir. Fine, sir. No problem, sir.
Yeah, yes.
Okay, so.
Yes, sir. So I invite Dr. John Mukhopadhyay, and he'll be talking on salvage in non-unions, please, sir.
Okay, so I need to share. Okay.
Yeah, first open this file and then share it.
Yeah, is that good?
Yes, sir. Yes, sir. It is coming full. No, I think.
Now
Yeah, right. Yeah, right. Yes, okay.
Okay, so I'll be brief because we are kind of stretching our time a little bit. So I think we can get these patients at various stages with problems following proximal humerus fractures, either early during the course of treatment because of some complication, or late with non-unions, malunions, implant failures, or infection. So you can get some unexpected complications sometimes, and this is a gentleman in his 40s who had this fracture dislocation. And I think most of us would do a closed reduction and then look at the tuberosity and decide whether we need to do any operative fixation or not. And this was what was done somewhere, but what happened was during the course of the reduction, I don't remember, I don't have in the records whether this was done under anesthesia or without, but this is what it ended up with. And the head remained there while the shaft came back to the tuberosity. So it became now a fracture dislocation with a neck fracture as well. So from a 2-part fracture dislocation, it became a 3-part fracture dislocation. And about 10 days after that, he presented to us. And so we did, this was before the era of lock plates. So we did it through a deltopectoral approach. We actually did osteotomy of the coracoid to make this retraction of the conjoint tendon easier. And we used a conventional plate, T plate, which we used to in those days, and fixed it. And this was the post-op position of the x-rays. And we kind of lost him to follow up until he came back 4 years later with another patient, and luckily he had done quite well. If you look very carefully at the x-rays, maybe there's some signs of some AVN with some backing out of the screws, but because they were conventional screws, they backed out rather than go through the joint, and he ended up with a fairly good function with healing of his fracture. Here's another case where the technical problems with fixation with the lock plates you have to be aware of. This was a proximal humerus fracture, and this is how it was fixed. And if you see the position of the plate, the reduction, they're all faulty. And he came to us 25 days down the line. And one of the good things, luckily, as a result of this was that if you looked at the head, there were hardly any screws that actually went into the head. So this is one of the issues with the lock plates, because the screws lock onto the plate, you may not get the biofeedback that you would get normally. And so you don't know what the screw is holding on to. Anyway, so we had to go in, get the fragments reduced, put the sutures on the tuberosities as we are supposed to, and then we went ahead and fixed it with this lock plate. And luckily, this is the last follow-up we had was at 2 months. He was doing well with it, with the fracture going on to heal, with him regaining function as well. So these are the kind of early problems we sometimes get in the fixations. Either they haven't been done properly or there's a delay in diagnosis, etc. What we get later on are the non-unions or the malunions. Non-unions, as has been discussed, are not common, but when they do develop a frank non-union, there is significant disability. They can have pain, they have weakness with a flail limb, and surgical treatment can be challenging. And it's interesting, in this paper by Court Brown, with I think more than 1,000 cases, they actually said that the prevalence of non-union was as low as 1.1%. But if there was metaphyseal comminution, it went up to 8%. And if there was more than 33% translation, it went as high as 10%. And they also said that there was a deterioration in the glenohumeral function if these fractures fail to unite. Now, what are the problems that you have to deal with in the non-unions? Okay, there's the non-union that you have to deal with. The shoulder joint in itself would be stiff. There's fibrosis of the soft tissue. There'll be instability at the fracture. The fragments may be malpositioned. You have loss of bone stock. And sometimes these head fragments, if they are lying without function for a long time, really become very osteoporotic. Is there a room for conservative treatment? Of course, if the symptoms are minimal, you can do it. But otherwise, you need to think of some form of fixation. And today, I think the lock plates really form the mainstay of fixation. Arthroplasty would be considered where reconstruction is not considered possible, and that has been discussed. So this is one of the earlier cases we treated with the lock plate, a 60-year-old lady who presented with 8-month-old non-union, and she had real trouble lifting up. So you can see even at 8 months, there's a frank non-union here. Of course, the CT confirmed it. You can see a clear non-union here with sclerosis of the ends and obviously an osteoporotic head. So here we used iliac crest corticocancellous bone graft fragment. So you can see the bone graft which was put in there on the medial side, some of the screws going through the bone graft. There's a post-op X-ray, and at 16 months follow-up, she recovered reasonably good function, not full internal rotation as you can see, and not full abduction, but a reasonably good function considering for 8 months she was unable to use the arm. Now, as I mentioned earlier, sometimes this lady who came 6 years after injury, you can see how osteoporotic the proximal fragment is. I mean, there's hardly any bone there. I don't think we really needed a CT, but it was done. And you can see the head really doesn't have any bone here. And here's where I think the intramedullary fibula comes in handy. You need to put it into the humerus and into the head as well, get the alignment right. Here's some extra corticocancellous bone graft and the fixation. And this is her at 4 months. You can see how nicely she's gone on to heal. And because A lot of these screws are actually going through the fibula here. It gives you a very good purchase. Some of these screws are going through it. So even on the shaft, you get an excellent purchase. And she got back a fairly good range of motion and function. Some of the literature on non-unions, if you looked at the early literature in the 90s, the results were fairly poor, with only 48% getting good results in this paper. And in this paper by Ring et al. Here, using a sort of blade plate, slightly better results, with 20 of 25 patients getting good to excellent results. With the lock plate and the use of the intramedullary strut allograft, Badman et al. Got much better results, close to 94% radiographic union. And so I think lock plates, and where necessary, a fibular graft, we don't use them routinely, but in some cases where the bone is very osteoporotic or you expect a lot of stress on the implant, the intramedullary fibula certainly plays a part. Interesting, this paper by Dr. Maheshwari, again using lock plates, but here he did not do anything to the area of the non-union. He just put a medial strut graft and fixed it with the screws across as a support for the head. And he showed very good results with this, and I think 6 out of 7 or 8 cases which healed up. And this interesting paper from the Resch group, where we talked about the Resch device. This is what it looks like. It's got these threaded wires, this block, and this tension band wiring. And they showed good results even with non-unions using this technique, where you had a very small fragment of the head. Using this Resch technique, they were able to get good results. What about failed fixations? Okay, I think this becomes even more complicated, because on top of the other problems, you have the problem of implant removal, especially if it's been a lock plate that's been used. You have even more fibrosis. You may have infection, and you may have even further bone loss. So this is a young gentleman who presented to us a long time ago. I think this was before the Philos, when we had the proximal humerus lock plates. He had 2 previous surgeries, and this is what he presented to us with at about 17 months after his original injury. Again, you can see the scalloping of the bone here with the gap here, and obviously lysis because of the mobility at the fracture site. And here we used a corticocancellous strut graft to fill the cavity, as well as the lock plate fixation. That's where the strut graft was. And this is him at 6 months. You've seen he's gone on to heal. This gentleman was from Afghanistan, and he hasn't come back after this, but he had some relatives in Patna who asked him to come here and see me. Another gentleman, 50-year-old. Again, if we looked at some of the cases shown by Dr. Pandey, maybe a case where conservative treatment might have helped, but this is what was done. And now you can see the tuberosity has gone even further up. This is the kind of position that he came to us with. And this was about 9 months down the line, 1 year down the fixation. That's what he came to us with. And obviously things were going on to fail. And here we had to go in, so we tried to get the tuberosity down as well and fix it with these threaded wires apart from the lock plate. And at 7 months, he had gone on to heal his fracture with a fairly good functional result. This lady who came to us 6 years after her original injury now, she had surgery 1 year for a non-union. This was the plate that was used, and this sort of failed fairly soon, I think within about 4 or 5 months of the fixation. And then the proximal fragment was lying in this abducted position, while the distal fragment was lying sort of vertically down. And this was a big issue, because you'd have to think of not only the non-union, the poor bone stock, the previous implant, the fibrous tissue in the fracture site, but also of the position of the proximal fragment. So you really need to release adequately to get this fragment to a reasonable position where you would expect your implant to hold. So here was another situation where we had to really release the subacromial space all the way around the rotator cuff area, all the way around to get a good release of the proximal fragment to be able to bring it down. But we also used the intramedullary strut fibula with screws going through the fibula to augment our fixation. And this is how she was at 8 months post-op. So even in these really late non-unions where they've been without function for many years, if you can get the anatomy restored, you can get the fracture healed adequately, they should get back fairly good range of motion and function. So it is worth trying to do in these cases. What about malunions? I think there are various types. Again, the tuberosities can be very difficult to deal with, but the neck malunions, which are in varus or different positions, you can do an osteotomy and get it back to get good function. So here was a relatively young gentleman, and here we did a anterolateral wedge here to get it reduced. And this was again with the proximal humerus locking plate before the Philos plate was available, but you can see how we've been able to restore the position. And this is him at 2 years 4 months post-op, back to a good function and a good result. So I think this was a case where they did this valgus wedge osteotomy, a paper where they did this valgus osteotomy with fairly good results. 3 had excellent results and 2 were good results. What about infection? I think this is a problem that is even harder to deal with. This was a patient who's within 3 months came with this discharging wound and the plate implants that had completely gone off. So here we had to do a thorough debridement. We decided to use an external fixator, but we used hydroxyapatite coated pins and we docked the fracture nicely in this position. We used antibiotic beads, got the infection under control. He went back and he came back only 6 months later. And by that time, the fracture seemed to be going on to heal. The initial plan was to convert to internal fixation once we got the infection controlled, but he came back 6 months later. And by then, although there was some collapse into varus, the fracture had healed. So we just took out the external fixator, and you can see now the fracture has gone on to heal quite well. Missed posterior dislocations, that's another problem where if the initial diagnosis is missed, and this patient came to us more than 6 months, close to 7 months after injury. And if you see the lateral, you can see the dislocation there. CT shows you the sort of big gap in the bone with the area of the lesser tuberosity. And here, to approach this, you often have to do this osteotomy here. And the idea is to osteotomize this and then use that to fill the defect in the head. So difficult to do at 6 months, but you go through the rotator interval, get to the back, release the tissue, and then get the head back in with using the McLaughlin procedures, modified McLaughlin procedure. We actually used, I've missed out that x-ray, we actually used a K-wire initially to hold the head in position. This was him at 3 months post-op, and this is 13 months post-op and 2-year follow-up. You can see, although there's some signs of AVN, you can see the head is healed and reasonably well with a fairly good function. So even these, and the posterior dislocation, some of the late cases are really worth doing because the results are quite gratifying. And even if the x-rays don't always look great, they get back a fairly good functional result. So to conclude, I'd say that neglected fractures of the proximal humerus are a challenging problem. I think non-unions usually cause significant disability. There are some patients with fibrous non-unions who function reasonably well, but we've had some of these then sort of having a minor trauma, then sort of shifting this fibrous non-union and then having trouble. I think successful treatment of these non-unions are possible with proper techniques. And I think you should reserve arthroplasty for the elderly with very high non-unions where reconstruction may not be possible. Otherwise, I think a lot of these, it's still possible to salvage the joint and get back reasonable function with proper techniques of fixation and bone grafting where necessary. Thank you. Okay. So,
thank you, sir.
yeah. So any questions, we can take that and then we can go on to the, whatever.
There's a couple of questions to Dr. Pandey. That one of the viewer has asked, let me tell you that at present the viewers are 2,000 with us. And one of the viewer has asked that if the head fragment is without a metaphysis, metaphyseal spike is considered to be avascular and should not be treated conservatively. Is it right or wrong, sir?
Well,
Dr. Pandey, please.
whenever such blanket statements are made in orthopedics, they are generally wrong. It is
Yeah.
somebody's personal opinion. I think it's not
Yeah.
just one thing which decides whether by doing an operation, how are you improving the blood supply?
That is true.
Yeah, so you need to be very sure that by doing the operation, all you're doing is you're improving the X-ray and maybe mobilizing the patient slightly earlier. So it's not just medial spike or lateral spike or the tuberosity is broken. You have to assess the whole fracture, and you have to remember that there is a patient attached to this fracture. So what is his requirement? If he's an 80-year-old or a 75-year-old or a 40-year-old, the treatment will be different as to what the patient wants. So I would say, are you going to improve the blood supply with surgery? No. If you're not going to do that, then treat the fracture as you would treat the fracture in a particular patient.
And one more question to you: that is there be any role of abduction splint in shoulder in doing the conservative management?
So Vikas, maybe you can put on your screen while your case, and then we'll have Ashish's at the end there.
No, in my practice, there is no role for abduction splints for conservative management of proximal humerus. It's a very, very uncomfortable splint to wear. You know, imagine if your arm is like that, you can't get through the door. I mean, maybe you can social distance better, but it is an extremely, most people wear it in the hospital. When they go home, they take it off. And then when they come back for follow-up in the hospital, they put it back on. That is my feeling. So I would avoid any sort of special abduction.
Right. So we'll go to the case discussion. So Dr. Vikas Agashe, please.
Yeah, can you see my screen? Full screen?
Yeah, full screen.
So I call this case as a floating shoulder plus. So this 63-year-old man presented 4 days after a vehicular accident. You can see the significant abrasions, soft tissue damage, penetrating injuries here with clavicle comminuted, scapular injury, glenoid injury, and the humerus in several pieces. Non-hypertensive, he had multiple glass pieces that were taken out. See, he was traveling in a car and the car was hit and he had a direct injury there, and multiple glass pieces had gone inside. They were removed on day 1, immediately after the accident, and 2 days later he started developing purulent discharge, which was collected, and when he came to our place, he was carrying a report that that pus had grown, staph and pseudomonas. And this is where we are. His finger and hand movements and sensations were normal. Elbow movements up below the elbow, sensations were okay. It was very, very difficult to examine his elbow movements. Distal pulsations and circulation was okay. To add to the problems, he had multiple fracture ribs and some hemopneumothorax. That's his CT. Part of the glenoid distally was intact, but proximally the glenoid was fractured in several pieces. That's the head partly. That is the head which is turned away, and several pieces here. Extensive scapular injury. That's the glenoid seen from this side. That's the CT. So question is, obviously debridement one has to do. When would you fix? How would you fix, or would you conserve? And finally, the relatives would ask, what is going to be the outcome? Can infection come under control? And most important, can he do his activities of daily living, and can he do a little more like driving a car, do overhead activities, etc. So I throw this open to the panelists. Dr. Pandey, what would you think?
Oh, you chose me. What have I done to you? Well,
That's the question I asked. That is the question I asked the patient also.
Yeah. So I think the initial management of this patient is not make sure his chest injuries are all sorted. There's no rush to do anything to the fracture. Infection is absolutely vital here. I mean, that has to be controlled. A good skin cover has to be there. Have even 80% of what he could do today. Whether he will drive a car and overhead activities, my opinion, I don't think he'll be doing a lot of overhead activities. Now, whether he drives a car or not, only time will tell. But I will paint a slightly poorer prognosis to him and his relatives, considering what we see. And I have to sort of tell him that initially we should try to save your limb.
Correct.
And then we will talk about other things.
Yeah.
Life, limb, and then other things.
Yes.
Yeah.
Yes.
But okay, so providing, okay, he's had his chest tube in, he's stabilized, and
Correct.
to deal with the infection, apart from debridement, don't you think stability of the fracture is important?
Yes.
I mean, that's a very good point you make, John. But in if it's a long bone fracture, absolutely. But in a shoulder injury where there is a lot of soft tissue there, yes, if there is a neurovascular compromise, then maybe you want to go and fix the clavicle only. But I would not do that by conventional techniques. Maybe you can put external fixator on the clavicle just to stabilize it. But I'm very reluctant to put anything there at the moment. If I can somehow try and get over the infection without putting metal work in there. So you will get plastic surgeons involved and get a thorough debridement done, and make sure you get some sort of healing. Even if you get some sort of healing in a couple of weeks' time, then I would think about doing something for the clavicle and see what happens.
Yeah.
Any thoughts, Dr. Tirchai?
Yeah, it's so complicated. So I agree. You have to get rid of the infection first, and yeah, wait until good wound condition, and you fix the head split and the clavicle. I think it should be look at the patients and see what is the progression. Yeah.
So yeah, so I mean I would agree, but I've found we've done a few cases like this, and we tend to really go in and debride, and then the problem is an X-fix is not a realistic option here. And today with the lock plates, we sometimes would go ahead and fix the fracture as well and get a good flap cover as soon as possible, and use that as part of your infection control itself, because it's early yet, it's only 2 days. I don't think the biofilms, etc., would have formed. So if you really do a radical debridement, maybe this would be the best time to fix the fracture as well.
I mean, Ashish, any inputs?
No, I agree. The infection for 2 days old patient is not a big deal. Your best chances to go in now.
Yes.
You said he was 60 years old, right?
63, yes.
Yeah, so I would stabilize the clavicle rather than do something open and big. I would do an intramedullary clavicle fixation there. And then on this side, I would debride thoroughly and use either a plate to get this humerus in position. And I might defer the glenoid depending on what time I spend during surgery. But he would need a glenoid fixation. If everything is open and I'm right there, then I might as well fix that as well, because it looks like a superior inferior type fracture. So that if that's a type 3, then I can just put a superior to inferior screw, and that works well to the Neviser portal.
The glenoid appeared quite comminuted. I just show the CT here.
And it's extending posteriorly, so it would be a bit difficult.
Posteriorly, yeah.
Yeah. So I think probably, anyway, let's see what you did because we are time. Yeah.
Obviously, I said we'll have to wait for a couple of for a day at least. So the plastic surgeon, my colleague Vivek Shetty, and myself, we just sat together and planned, and we felt that we need to excise that skin. There's no doubt about that.
Exactly.
So that skin we planned to excise. Then we planned to take a deltopic. We felt that unless we stabilize the humerus and clavicle first, because otherwise the entire brachial plexus may be pulled down. So we thought we'll fix the clavicle and open this after excising the skin and fix the humerus.
Yeah.
So clavicle and humerus we decided to fix on the same day because we thought that otherwise, as John said, that we will not have good stability to fight the infection. So that was the plan. So this was deltopectoral. So we did interfrac screw fixation and fixation of the clavicle. That's the head. You can see that's a part of lesser tuberosity with head. That's other part of the head. And that's the fixation we achieved. The lesser tuberosity is fixed to the head. And if you notice, this is the first version of humerus locking plate, PHLP.
PHLP.
Humerus locking plate. This was before the Philos came in. There was a year or so where PHLPs were available. So that is what we got. And we had to explore the wound twice because the deltoid just kept on getting necrotic. So I had to be very, very aggressive in taking out all the necrotic tissue. This is the CT, just to reconfirm, and wanted to check the, check the glenoid, and the glenoid was markedly comminuted. So we really decided not to do anything for the glenoid. And this is him. We did an EMG which showed C5 root avulsion, and that is him at about 3 months. That's at 3 months. He had started doing no pain, of course. He had no active abduction, but other movements were reasonably good. And he was doing almost all activities of daily living. This is at 16 months, healed fracture, very comfortable, can lift in up to here. Obviously, no abduction at all. He has some scapulothoracic movements, but the hand can lift about 5 kilos. He can't obviously do overhead activities. He travels by air, but he says he asked someone else to put the luggage into overhead compartment. But apart from that, he is almost able to do everything. So this is where we are.
Yeah, I think so. That's a good example of where sometimes you need to fix even where situations are not ideal, because stability is part of your fight against infection.
Right.
I think it didn't seem to need a flap. Yeah.
No, we did a split thickness graft. He didn't need a flap. That's his incision. That is what we had excised. And because of the humerus, I think there was decent cover. We could get decent soft tissues, and then we did a split thickness graft.
Okay, so I think Ashish, one case, and then we should call it a day. Is that okay?
Sure.
Just take one of the two, whichever one you prefer. And because we are close to 3 o'clock. Yeah, people would be dying to get lunch.
I can imagine. So instead of asking questions how to go about it, I'll just run through what we handled it. I would have loved to grill the panel. It was a unique opportunity, but I guess we'll have to pass that.
We're happy you don't have to do that.
This is 58-year-old gentleman, came from Konkan, which is about 400 kilometers from here, and he had a comminuted fracture proximal, bad one, documented axial nerve damage, 80% sensory loss, and these were his CT scans, split head as well, lot of fragments, and that was his 3D. So I think the 3D makes much more sense than a 2D. So it's important to ask for 3D reconstructions. Quite clearly, 58, I was inclined to do a hemiarthroplasty, but that dilemma of presence of axillary nerve is always a compromise. Now, looking through literature, it was that almost 80% of axillary nerve injuries will recover. In the presence of axillary nerve injury and a nasty fracture, it was important to stabilize the fracture to give the nerve a chance to heal. Otherwise, the whole construct of the fracture will pull and continue pulling the axillary nerve down. So we had to read the Riot Act, take his consent, and we explained very clearly that if the axillary nerve doesn't work, this is going to fail and you might need a complex revision, but we are expecting 70 to 80% chance for it to fail. Were it not to recover, we would consider another surgery as such. And so we went in and did a decent job. We put everything together. You can see it's very unusual for me to use cement, but because it was a complicated fracture, we put in there. We got a couple of wires across and got the tuberosities in their position as well. And everything went quite well. We actually managed to get the tuberosity healed. This is the trauma stem. It has a hydroxyapatite coat and everything heals nicely. You can see by virtue of the axillary nerve injury, the whole construct is inferiorly subluxed. This was 6 weeks after surgery, that X-ray. And then at 4 months, he came and he said the sensations have improved. From 80% loss, they've come down to 40%, but motor-wise, it was doing nothing. So his supra was grade 4, infra and hornblowers was grade 3. We were unable to give him a rehab because there's no motor drive there at all. So we repeated his EMG and we found no healing potential at all. There were still denervation changes, no signs of reinnervation. So polyphasic signals were still persistent. So we decided that we go in and explore. And we said that if the axillary nerve is significantly damaged, contused, and we would stimulate the axillary nerve, if it were not to work, then we would actually go ahead and do a Somsack procedure. So Somsack procedure is where we would use the radial nerve to the medial head of triceps and transfer it to the axillary nerve. It works much better than a graft because you get a ready-made supply to feed the axillary nerve. And having gone in there, we actually found that the axillary nerve was okay, contused. There's a lot of scar tissue around the axillary nerve. So we just did a decompression of the axillary nerve. We usually use a very light muscle relaxant so that we can stimulate the nerve. And after releasing the psychiatrics, we realized that the nerve was firing better. We could actually elicit deltoid contractions, all 3 bellies. And so we just did a thorough decompression. Okay, this is one of the 3 cases that we have done where we've actually had to go in and repair. And you can see the clips there from the vascular exploration and clipping. And this is his result. And slowly you will see at 6 months that head of humerus come back again to the home position. It was a mighty relief to see that because that means that the deltoid has started firing and functioning. And this was his result. This was October 2017, still struggling, pain. The shoulder looked heavy. And this is his September 2018, a year back. Again, his review is usually in September. Last year he came in November. He's done better than this. So he's got active. Now he's 120, 120 and 40 degrees external rotation and continues to improve. My impression is they continue to improve for almost 18 months after the nerve surgery. But most importantly, his pain has gone. His proximal, his distal migration has corrected. His wasting has reversed and his active movements are reasonably okay. He's able to do his work. You will achieve rotations after a hemiarthroplasty, provided the motor nerve is working, provided the greater tuberosity is integrated very well. So look, here you can see that all that wasting has recovered completely. He's got his normal contour back, so that was a big relief. But these can be challenging cases which can go significantly pear-shaped. So his power has also come back. Thank you.
Great.
Thank you very much.
Okay, so that's great. So I think if there are no burning questions, we should.
Sir,
Yeah, one last question to Dr. Ashish. Yeah, Dr. Arvind Gupta has asked one question to Ashish, that how to restore the version in hemi shoulder, and is it vary from patient to patient? And if yes, then how to identify that?
Right. Arvind, there's a very long, lengthy answer to that. We will starve the audience today. But to cut the chase, number one, every one of us has a unique version. In fact, our left and right shoulders have different versions to each other. That was based on a paper we published in the Journal of Anatomy. You have to evaluate version intraoperatively. You can evaluate it on CT scans preoperatively in somebody who's not fractured, but that's besides the point. So in intraoperatively, you have jigs by the companies, you can evaluate it. We usually use the transepicondylar axis to confirm that. So that requires a little bit of practice and understanding, but we'll probably use that as a subject for next time. But it's important to replicate the version so that the force tension and the length tension between the scapulohumeral muscles is exactly as it was pre-trauma. Then they will get back that full function.
Can I just say a few?
Sure.
One. So one thing we do here in Leicester, we have not buried all our hemiarthroplasties. So we still do some hemiarthroplasty. And in certain places in India where you don't have anything else, hemiarthroplasty may be the only option available. So, but there are two things we need to be very clear about. The hemiarthroplasty, as Ashish says, depends on how the tuberosity is healed. So the most important thing is if you have a good chunk of the greater tuberosity, then a hemiarthroplasty, well done hemiarthroplasty will work. Just make sure that tuberosity is not a mush or very comminuted or very small fragments. That's one. Secondly, as Ashish says, you need to use a fracture stem. Not only that, you need to use what is called a platform system. The platform system is a hemiarthroplasty which you can convert to a reverse shoulder without removing the stem. And I think people should see if they can get hemiarthroplasty which has got a platform stem, because it's not always possible to convert it, but I have done it few times and it's always a great thing to have it. The third is axillary nerve. If there is a partial axillary nerve, most of the time it will recover. It just requires a big heart and balls of steel, as they say, which most of the orthopedic surgeons have. Just have to hang in there, monitor it very carefully with the EMG. It may take up to a year for it to recover.
Yeah. Okay. So Rajiv, I think you. I think
Sir, there is a case by Dr. Mahesh Sone. Shall I read? Say so, sir.
Yeah, one quickly, please, to all the panelists, just quickly, advise him. It's a fresh fall, 45-year female. That opinion of the house, please.
Is there any other X-rays?
Do we have any?
Single
we need some more views there. Oh, just one X-ray.
And
yes, sir.
At 45, the upper end humerus looks little odd. Did she have any other problem earlier?
Yeah.
No, sir. It's a fresh. Today's history got this X-ray only.
So,
yes, John, you go.
I would say just looking at this, it would be one that would probably need fixation, but I would definitely get a lateral and maybe even a CT, because I think the tuberosity is off here before making a final decision.
I agree with John. Just make sure there's no neurology there. Firstly, this is not an adequate, I won't go do anything till I have more views and a CT scan. Then you can, I think this is, even I would suggest we should try and fix this. How you fix it depends on what you are good at.
Yeah.
I would have nailed it. I'm sure John would have, and Ashish would have plated it, but this is not for replacement. But whatever fixation device you use, just make sure you are good at it. And if you're not very experienced with this kind of injuries, just send it to somebody who is.
Yeah. So I think, I would agree with that. Okay. So,
yes, sir.
So thanks to all the faculty, and I think Rajiv, I'll hand it over to you.
Yes, sir. Thank you very much, all the panelists and all the presenters. I especially thank Dr. Vikas Agashe and Dr. R.K. Pandey and Dr. Tirachai. I think he has just left. He has asked that he is leaving. And I especially thank Dr. Ashish Babulkar from Pune. And of course, our mentor, Dr. John Mukhopadhyay, who has conducted so nicely. And it's a matter of great pleasure that 2,000 plus viewers were with us. And it was a wonderful show. And I thank my president, BOA, Dr. Manoj Chaudhary. And thank you very much. And thank Samshul, who you have conducted so nicely. Thank you all.
Thank you.
Thank you, sir.
Thank you.
Thank you.
Thanks,
Bye-bye.
John.
Rajiv,
Thanks,
Samshul.
Rajiv.
Thank you. Bye-bye.
Thank you.
Thank you, everybody.
Bye.
Thanks, Harshit, Vikash.
Bye.
Thank you.
Bye, everybody.
and